Very good afternoon to all of you, and very warm welcome to all the participants to this day 3 of training program. And as you know, today we will discuss mainly about the mechanical ventilation in children. So we have 6 lectures today focused on mechanical ventilation in children. So the first is the basic terminology of invasive ventilation, and later on we will have lecture on multi-para monitor, the indications of mechanical ventilation, various modes of mechanical ventilation, endotracheal intubation, and how to initiate ventilation in various settings, and finally the weaning and extubation. So we are starting with the first lecture, and the first topic will be taken by Dr. Manisha Maurya, and she is from MLMNC Prayagraj. So I welcome Dr. Manisha, and she will be talking about the basic terminology of invasive ventilation in children.
Thank you very much, ma'am. Today we will be discussing basically on invasive ventilation. For invasive ventilation, we all should know some basic terminologies which we usually set on a ventilator, and the various phases on which a simple ventilator works. So my lecture will be totally based on basic terminology of invasive ventilation. Now the specific learning objectives are concepts of basic parameters of mechanical ventilation, parameters that control oxygenation, parameters that control ventilation, and video demonstration of how to set up a ventilator. Now first terminology is the respiratory rate or the frequency. Respiratory rate is the number of breaths the ventilator will deliver in 1 minute. We set this on a ventilator. There is a button of respiratory rate. And for every invasive ventilation, we have to set a respiratory rate. The initial rate which we set on a ventilator is according to the physiological rate for that age. As we have discussed in day 1, the various physiological respiratory rate for different ages. For example, if it is a newborn, the physiological respiratory rate may be around 40, 45, 30 to 45. Then if it is a child less than 1 year or an infant, then the respiratory rate would be around 30, 25 to 30. If it is a child less than 5 years, it may be around 20 to 25. Above, maybe around 18 to 20. And in adults, as we all know, 12 to 14. Then the rate what we set is according to the physiological rate, and titration is done according to the PaCO2 level, which is available on the ABG reports. So since respiratory rate is determinant of minute ventilation is product of tidal volume and respiratory rate. Thus, it determines carbon dioxide elimination. So whenever we have to manage PaCO2 level, we have to titrate respiratory rate so as to have a eucapnic ventilation. For example, if we have done a ABG and the carbon dioxide level in ABG is going beyond the hyperpermissive carbon dioxide, that is permissive hypercapnia, maybe around 55, or if the respiratory rate is causing respiratory acidosis, then we have to manipulate or titrate respiratory rate so as to cause increase in washout of carbon dioxide and to normalize the PaCO2 level. Now the next setting which we set on a ventilator is tidal volume. Tidal volume is the volume of air delivered to the patient during a ventilatory breath. Tidal volume is preset on a volume control mode. There are basically 2 control modes. One is volume control mode and one is pressure control mode. So in a volume control mode, we have to set a tidal volume, but in a pressure control mode, we set usually the PIP, and the tidal volume is variable according to the lung compliance and the airway resistance. The tidal volume can be variable. So whenever we are setting in a pressure control mode, we always have to monitor the tidal volume, whether the tidal volume is being delivered to the patient is adequate or not. And the initial setting we set on a ventilator in a volume control mode is 6 to 8 ml per kg, And in a pressure control mode, we have to go and see whether the tidal volume being delivered is at like this, that is 6 to 8 ml per kg or not. And tidal volume is also the determinant of minute ventilation. That is, tidal volume is the product, minute ventilation is the product of tidal volume and respiratory rate. So it also determines ventilation. FiO2. FiO2 is the fraction of oxygen in the inspired air gas mixture, and it is set from around 21% to 100%. It also improves oxygenation, and its values are titrated or adjusted according to the PaO2 level and SpO2 level, and we have to keep this, we have to manipulate FiO2 so as to keep this PaO2 and SpO2 level in the acceptable range. PaO2 we get in a ABG, as we have learned in yesterday's class, that if PaO2 level, the acceptable PaO2 level may be around 60 to 18 pediatric age. So if it is less than this, then we may have to increase the FiO2 level. And the acceptable SpO2 level is around 92 to 94%. So if the SpO2 level is falling, we may have to increase the FiO2. But whenever we are setting the FiO2, we always have to remember that FiO2 more than 60% may not be good for the patient. It may cause oxygen related toxicity. So we have to try to keep the FiO2 to less than 60%. Initially, we can start with 100% oxygen. Once the patient is stabilized with other parameters like pressures and tidal volume, we have to decrease the FiO2 level to less than 60%. Now the next parameter which we set on a ventilator is PEEP, which is the most important parameter. It is positive end expiratory pressure, or is the pressure maintained at the end of expiration. The main function of PEEP is to improve the ventilation perfusion matching and oxygenation by decreasing the intrapulmonary shunt. Intrapulmonary shunt is the amount of blood which is coming from the heart to the lungs for oxygenation is going again to the lung unoxygenated. So whenever the intrapulmonary shunt is more than 15 to 20%, it causes hypoxia and decrease in oxygen concentration. And by increasing the PEEP, we can decrease the intrapulmonary shunt and increase the ventilation perfusion matching, thus improve the oxygenation. So the second function of PEEP is, that is positive end expiratory pressure, is to increase the functional residual capacity, FRC. Functional residual capacity is the amount of air which is left in the lung after normal exhalation. So we always want to have some amount of air left in the lung after normal exhalation so as to keep our alveoli inflated. It should not collapse. So whenever in the next inspiration, the patient or the person will not have increased effort to expand whole of the alveoli. So some air has to be left. In a diseased condition, in a diseased lung, most of the alveoli may be collapsed. So the PEEP just recruits this alveoli, collapsed alveoli, and distends the alveoli, thus improves the lung compliance and improves the oxygenation of the patient. This is a simple diagram. We can see in this is our alveoli which is partially collapsed. We have given a low PEEP. So in this we can see ventilation is not proper but perfusion is good. So this is an example of ventilation perfusion mismatching. In this diagram we can see it is over distended alveoli. We have given very high PEEP, which is causing compression of the vessels or the perfusion. So perfusion is hampered but ventilation is good. So this is also an example of ventilation perfusion mismatching. Now in this diagram we have given optimal PEEP. So we can see that both the ventilation and the perfusion is optimal. We have matched ventilation and perfusion. Thus we have improved the oxygenation and decreased the intrapulmonary shunting. But while setting a PEEP, we always have to remember that high PEEP may lead to overdistension of the lungs, and this overdistended lungs will cause the decrease in venous return to the heart. Decreased venous return to the heart will ultimately decrease the cardiac output and cause hemodynamic instability and sudden or a decrease in BP. So we always have to monitor the blood pressure whenever we are giving or applying high PEEP to the patient, and always remember that high PEEP may cause decrease in cardiac output, and high PEEP may also cause air leakage. So it can also cause like pneumothorax or pneumomediastinum. This thing has to be kept in mind. The initial PEEP which we set on a ventilator in children is around 3 to 5 centimeters of water. And in a case of ARDS, like in ARDS, in a COVID pneumonia, COVID ARDS, we can start from 8 centimeters of water also. The next parameter is PIP, that is peak inspiratory pressure. Peak inspiratory pressure is the highest pressure which is reached during the inspiratory phase. That is, in one breath, the maximum pressure which is reached is called the peak inspiratory pressure. Peak inspiratory pressure also improves the oxygenation, and inappropriately high PIP, that is peak inspiratory pressure, as the PEEP does, may also cause air leaks and barotrauma. This thing has to be kept in mind. In volume control mode, where we don't set PIP, the PIP is variable. So whenever we are setting, we have put the patient on a volume control mode, we have to monitor the PIP. And if we find that there is a sudden increase or there is an increase in PIP, that it may indicate airway pressure or airway resistance in the airway. And this airway resistance may be because of secretions, bronchospasm, and mucus plugs. And these things can be taken care as secretions. We can do suction. For bronchospasm, we can nebulize the child. For mucus plug, again, we can do nebulization and suction. So in a volume control mode, since PIP is variable, we always have to monitor PIP in a volume control mode. And if we find an increase in PIP, we have to go and find the airway resistance and manage it. The initial setting which we set a PIP in a child is 18 to 20 centimeters of water. So this is a simple diagram which can easily differentiate what is PIP and what is PEEP. So this is PIP, that is the maximum pressure which is reached in one breath is PIP, and the baseline pressure is PEEP, that is positive and expiratory pressure, which is maintained throughout the cycle. So in one breath PIP is reached, the PEP is maintained, then in again breath PIP is given and PEP is maintained. So PEP is maintained throughout the cycle and PIP is given in one breath by the ventilator. P plateau. P plateau or plateau pressure. Plateau pressure is the alveolar distending pressure, or the pressure applied by the ventilator to the small airways and the alveoli. For example, if we know that the ventilator gives a PIP, that is, it provides peak inspiratory pressure. So when this peak inspiratory pressure is given, the pressure when it reaches till the alveoli, it goes to the various airways, and because of the lung compliance, the pressure when it reaches the alveoli may be somewhat decreased. So this pressure which is coming up to the alveoli is called the plateau pressure. Plateau pressure reflects the lung compliance, and it's usually kept below 30 centimeters of water. Plateau pressure we usually don't set on a ventilator, and it is excuse me, sorry for interference. This inspiratory hold we usually obtain, we don't set on the ventilator, we obtain it by doing a inspiratory hold maneuvers. These inspiratory hold maneuvers are there on the ventilatory display panel. We can have a direct button of inspiratory hold, or we can find this inspiratory hold button in the tool section or the setting section. We have to go there. We have to do the inspiratory hold maneuver for 0.5 seconds to obtain the P plateau, and this has to be always monitored, as P plateau, high peak pressure, plateau pressure going to the alveoli may cause barotrauma. So it has to be kept below 30 centimeters of water. Sometimes in a value section, we may find P plateau without having a inspiratory hold maneuver. These are false P plateau level. We always have to do the inspiratory hold maneuvers to get the P plateau levels. Now this is the diagram which easily depicts what is P plateau. peak pressure is given by the ventilator because of some airway resistance, or the compliance, the pressure which is reaching up to the alveoli, this is the P plateau, somewhat decreased pressure, and it is obtained by doing the inspiratory hold for 0.5 seconds. So we have given an inspiratory hold, we have obtained the P plateau. And sometimes if we find a very large difference between P peak and P plateau, that it means that there is some airway resistance and we have to manage it. In volume controls mode, we can find sometimes both P peak and P plateau which has risen up very high. Then it indicates that there is poor compliance. We have to manage this patients very properly, as high pressures in these poor compliant lungs may cause barotrauma, ear leaks, etc. So this is the diagram which we can easily see what is P plateau. Now next is mean airway pressure or MAP. MAP is the average pressure which is in the respiratory passage during the ventilation, or in simple language we can call it as the area under the pressure time graph. Area under the pressure time graph, and it is determined by PIP, PEEP, ventilatory rate and inspiratory time. So the area can be increased by all these parameters. We don't set MAP on a ventilator. We derive it by the formula, or we can get it on the value section. The MAP can be determined by the ventilator. It's displayed on the value section of the ventilator. So MAP is the main determinant of oxygenation. So whenever we want to increase the oxygenation, we may have to increase the MAP. And for increasing the MAP, we can increase either these parameters. The typical MAP is between 5 to 20 centimeters of water. Now, this is a diagram which is showing the area under the pressure diagram, this blue color. And this area can be increased either by increasing the flow, or by increasing the peak pressure, or by increasing the TI, that is inspiratory time. We can also increase the area by increasing the PEEP, that is positive and expiratory pressure, and by increasing the respiratory rate. So MAP is the determinant of oxygen. Whenever we want to improve oxygen, we can increase either of these parameters. The best one among these is PEEP, that is positive and expiratory pressure. The next one is the peak inspiratory flow rate, or we can say tidal volume upon TI, or maximum speed at which the set tidal volume is delivered by the ventilator. It is expressed in liters per minute. We can manipulate the inspiratory rate by manipulating the peak inspiratory flow rate, and this peak inspiratory flow rate button is usually found in the volume control mode. In a volume control mode, we can easily set the peak inspiratory flow rate. In some of the ventilators, in volume control mode also, we don't find the peak inspiratory flow rate button. In those ventilators, the peak inspiratory flow rate is set at a default about 60 liters per minute. It may range from 30 to 100 centimeters per minute. So whenever we want to manipulate the inspiratory time, either we can increase the flow rate. By increasing the flow rate, faster peak is achieved and shorter inspiration will be there. And if we lower the flow rate, longer inspiration will be there. The next one is the IE ratio. IE ratio is very important ratio, as it determines by this we can easily set the inspiratory time and the expiratory time. IE ratio is the ratio of duration of inspiratory and expiratory time. So IE ratio is basically the ratio of inspiratory time and expiratory time. The normal IE ratio which we set on a ventilator is around 1:2. And the ratio, that is inspiratory time, should always be kept as physiological as possible, since the respiratory rate of small babies, that is newborns, is towards the higher side. These babies have a small inspiratory time. So the inspiratory time in these babies may be around 0.3 to 0.4 seconds. For a child, that is infant less than 1 year, the inspiratory time may be around 0.4 to 0.6 seconds. For child less than 5 years, it is around 0.6 to 0.8 seconds. For child, bigger children and adolescent, may be around 0.8 to 1 second. And in older children and in adults, it may be around 1 to 1.2 and 1.4 also. So whenever we are setting this inspiratory time and expiratory time, this should be as physiological as possible. Since these values are not always able to be remembered, we have to go and see the IE ratio, and it should be try as far as possible to keep IE ratio in the ratio of 1:2. Sometimes we may have to increase the oxygenation. For that, we can increase the inspiratory time. As we have seen in the previous slide, inspiratory time increases the MAP. So whenever we want to improve oxygenation, we can increase the inspiratory time, but and have the ratio of 1:1 also. But when we increase the inspiratory time, we should remember that by increasing the inspiratory time, it decreases the expiration, it decreases the carbon dioxide elimination, and thus may cause airway, air trapping, and air trapping may cause over distension of the lung and decreased cardiac output. So this thing has to be kept in mind. So we can have 1:1, but reverse ratio shouldn't be done. And inspiratory time is usually manipulated whenever we have manipulated other things. So this is touched at the last. The second one is the whenever we want to have improved ventilation, that is, we want to increase the carbon dioxide washout for proper ventilation, we can increase the expiratory time, and the expiratory time may go from 1:2 to 1:3 and 1:4, as in the case of bronchial asthma and some obstructive airway diseases. The ratio can be increased also, but by increasing the expiratory time, more of the carbon dioxide, more of the air is washed out and may cause atelectasis of the alveoli. So this thing has to be kept in mind. Now, too less TI may lead to set tidal volume being delivered too quickly, resulting in high pressure, may cause barotrauma also, and too long TI will limit the respiratory rate, as we have discussed earlier, may cause hypercapnia, and increase the PaCO2 level. Now, phase variable. Phase variables are the variables upon which a ventilator works. It is trigger, limit, and the cycle. In this section, we can see this is trigger, that is what causes the inspiration to begin. B is limit, what regulates the airflow throughout the cycle. And C is the cycle, what causes the breath to end. So this is trigger, this is limit, and this is cycle. Let us discuss one by one. Trigger, what determines the start of inspiration. It can be of three types: time triggered, pressure triggered, and flow triggered. Now let us see one by one. Time trigger. Time trigger, breath is delivered once the preset time has been elapsed according to the set frequency. For example, in continuous mandatory ventilation, what we do, we set a frequency of around, for example, 20. So if we have set a frequency of 20, each breath is delivered at every 3 seconds. So it is time triggered, that is machine triggered. Machine gives the breath at every 3 seconds. Now let us see the pressure trigger. Pressure trigger is the trigger when ventilator senses the patient's inspiratory effort. So this trigger is started by the patient. Patient starts the inspiratory effort, and its effort is determined by the ventilator by decreasing baseline pressure. Once the ventilator determines the patient's effort, it assists that effort and gives the desired PIP or tidal volume, whatever we have set, and that breath is assisted by the ventilator. So it is pressure triggered. Flow triggered is ventilator senses the patient inspiratory. Again, in this, the ventilator senses the patient's efforts. So patient either decrease in baseline flow, or directly the inspiratory flow is sensed by the sensor which is there near the airway opening. So both is triggered, the pressure triggered and flow triggered. These are patient triggered. Patient starts the inspiratory effort, and the patient inspiratory effort is determined by the ventilator either by decrease in pressure, baseline pressure, or by decrease in baseline flow. And once the ventilator determines, it assists that triggered breath by giving the desired tidal volume or PIP and whatever setting we have given. Now, second one is the limit. Limit is what regulates the gas flow during the breath. So, if a variable like pressure, flow, or volume is not allowed to rise above a preset value during the inspiratory time, it is termed as limit variable. For example, if we have set a PIP, that is peak inspiratory pressure, of around 20, then the pressure will not go beyond, the PIP will not go beyond 20 throughout the breath, throughout the inspiratory time. So the breath delivery will continue, and that variable is held at a fixed point, that what we have fixed. For example, if we have set a tidal volume of around 250, so throughout the cycle, the tidal volume will remain 250 and will not go beyond that. So limit is the variable which allows the airway delivery throughout the breath. Now, the third one is the cycle. Cycle is what ends the inspiration. This variable is set as used as a feedback signal by the ventilator to end the inspiratory flow, which then allows the exhalation to begin. Volume cycle it is also of three types: volume cycle, pressure cycle, and time cycle. Volume cycle is inspiration ends when a preset tidal volume has been delivered. Pressure cycle is inspiration ends when a specific airway pressure has been achieved. And time cycle is inspiration ends when a preset time has been elapsed. So when we have set a time, inspiratory time of about 0.4 second, so after 0.4 second, the cycle will end and now the exhalation will start. And for example, in pressure cycle, if we have set a PIP of around 20, so if the 20 airway pressure is reached, then cycle will end and the exhalation will start. And if it is volume cycle, if we have set a tidal volume of around 250, then after the 250 tidal volume has been delivered, the cycle will stop and the exhalation will start. So this is the cycling. And most of the pediatric ventilators are basically time cycled and flow triggered. That, for example, if we have set a inspiratory time of 0.4 second or 0.6 second, then after 0.6 second, the cycling, the breath will end and exhalation will start. And if it is flow triggered, the ventilator senses the patient's inspiratory effort in the form of inspiratory flow. The practical applications of all these terminologies are basically either we have to increase the oxygenation, that is parameters. We have to know what are the parameters to which increases the oxygenation and what are the parameters which determine the ventilation. So whenever we want to improve oxygenation, we have to have a target PaO2 level or SpO2 level. We can increase either mean airway pressure or FiO2. So among these, the mean airway pressure is best, as FiO2 more than 60% is not good for the patient. And for mean airway pressure, the 5 parameters which we have learned in the previous section can be increased. So the mean airway pressure, either we can increase the flow or we can increase the PIP, PEEP, inspiratory time and respiratory rate. The best one for increasing the MAP is PEEP, that is positive end expiratory pressure. And the parameters which determine ventilation, so as to have normal PaCO2 level in ABG, we can increase the tidal volume or we can increase the respiratory rate. And among these, tidal volume is best used, usually used. Respiratory rate is usually used and tidal volume is not used, as if we increase the tidal volume, pressures also increase. So we usually don't touch tidal volume for increasing the ventilation. We usually use respiratory rate for improving the ventilation, for causing the carbon dioxide to wash. Now the various videos we'll be seeing at last. This is the diagram, a simple diagram of a ventilator. This is the oxygenation, central oxygenation connection, and this is the pipeline for central air connection. In some of the new ventilator, we only have a central oxygen connection, and for air compression, there is inbuilt compressor. And from there, the oxygen and the air, there is blender inside the ventilator, which blends oxygen and air and gives a desired FiO2. This is the ventilatory display panel in which various buttons are there. So as to we can set various parameters which we have studied till now. We can set this on this ventilatory panel. We can obtain the desired values which we want to know, which we don't set on the ventilator on this panel. And these are the electric supply. Electric supply is very important. We have to give 3 electric supply, that is 1 to the ventilator, 1 to the UPS and 1 to the compressor. And whenever we are finding any problem in this ventilator, we always go and see whether any of these electric supply has been missed or not. This is very important part. Then we have to connect the circuit to the ventilator and to the patient. In this circuit there is inspiratory limb and the expiratory limb, and then it is a HME filter, flow sensor which is connected to the ventilator. HME filter is heat and moisture exchange filter. HME filter is used whenever we are not using the humidifier, which is usually connected here. Humidified and heated air is very important, as dry air and cold air may damage the lung further. So this is very important to have a HME filter. And whenever we are using the HME filter, it is very important to have a pediatric size, as large size may cause the increase in dead space. And this is the test lung which we get in every ventilator to check whether the ventilator is functioning properly or not. We'll be seeing in the videos also. This is a simple circuit. This is a patient inlet. We can have bacterial filter if it is required. It's optional. Then inspiratory limb goes to the humidifier. In this humidifier, heated and humidified air air is heated and humidified. Humidification is usually done 100% and heating is done around body temperature 37 degrees Celsius. And then this heated and humidifier inspiratory limb goes to the Y piece. There is a water trap so as to trap the water vapor, and the water vapor doesn't collect in this pipeline. Through the Y piece, we can connect a nebulizer if it is required, or we can remove it. Then it is a flow sensor which is connected so as to obtain various values which we want to obtain from the patient and the ventilator. And from this, HME filter can be connected if we are not connecting to the humidifier. From the HME filter, either we can connect to the NIV mask, that is BiPAP mask, or we can connect to the ET tube. For invasive ventilation, we connect to the ET tube. And then from patient, exhaled here goes from this through the Y piece, through the expiratory limb, then to the exhalation wall to the ventilator. So this is a simple circuit, and some circuits there are differences, minute differences in circuits of various ventilators, and we will be discussing one of the example of this, how to connect the ventilatory circuit. So whenever we are getting some problem in connecting the ventilatory circuits, we can ask the technician of the ventilatory display unit, and they can come and connect how to tell us how to connect the ventilator and how to switch on the ventilator, how to connect various tubings in that ventilator. This is the simple display unit of a ventilator. This is on-off button, alarm system, rotatory knob. These blue squares are basically the settings which we set on the ventilator, and these black squares are settings which we obtain on the ventilator. So it is a pressure control mode. We get the tidal volume, and we can monitor whether the tidal volume which the patient is getting is adequate or not. These are the various graphs which we obtain on the ventilator, which can help us whether the patient is getting proper ventilation or not. Pressure time graph, flow time graph, volume time graph, pressure volume graph, etc. All these graphs are there on the ventilatory display unit. So these are the references. If one have to go have a detail about the topic, go and we can see these references. Changdi, IEP textbook of Pediatric ICU, and the skills to be learned are: it is important to understand and set all these parameters. Changes in the parameters should be done according to the patient's clinical status. So this is very important. Monitoring we are going to learn in the next section, and arterial blood gas analysis reports we had been discussed yesterday. And further practical implication will be discussed in the mode section, and the initial setting and titrations of these parameters will be taken further in the lecture. My sincere thanks to all the contributors of this wonderful module. My thanks to Shali ma'am, Dr. Chandrakanta ma'am, and DGME sir, all the panelists, and to the participants for listening me. Thank you very much. Now, Neeraj, Mr. Neeraj, are you there?
Yes, just a second.
Yes. Yes, okay. This one.
और ये हमने इसमें सर्किट और टेस्ट लंग तैयार करके रखा है। मैं आपको दिखा दूँ, ये फ्रॉम द पेशेंट दैट इज एक्सपिरेशन, एंड ये टू द पेशेंट दैट इज इंस्पिरेशन। ये फ्लो मीटर के लगे हुए हैं। ये वेरी सिंपली इट अटैचेस हेयर एंड स्पायरोमेट्री को, ये यहाँ लगे हुए हैं स्पायरोमेट्री। ये लाइन यहाँ अटैच्ड है, यहाँ पे हमने फिल्टर अटैच कर रखा है, और ये टेस्ट लंग अटैच है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। तो इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस पे लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है? ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया। ठीक है, आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ टेस्ट एंड कैलिब्रेशन होगा। पास, नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें प्रिंसिपल मोड यूज़ करना है अपने मोड के लिए, आपने स्टार्ट कर दिया और इंश्योर करना पड़ने के लिए कंफर्म कर देंगे, ये स्टार्ट हो।
Hello everyone, today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator, and the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port, and also the humidifier, and we'll connect the cable of the humidifier to the port, and we'll start the ventilator. This will see the charging cable, lights of the charging cable are on. This is the button from which we'll start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory.
Next video, please.
So these are the tubing, it has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber, which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned here is expiratory. So the expiratory port will go into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory limb. From humidifier, the broad end will goes into the humidifier chamber, and the second part into the patient limb. For timing, we'll attach the patient limb to the test lung. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode, and these two wires are there. So where to connect which wire? Since there are three ports, as you can see, we'll connect this proximal end into the inspiratory one, like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So and on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air will plug it down and push. Second thing which we will see on the back side is the flow sensor. So from here, the flow sensor wire is connected, and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with, the pediatric, like neonatal age group or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm, and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. We'll go on the main screen. I will connect it back. So this is the main panel. On main panel, you can see there are multiple things which is coming, and these are the modes. On baseline, you can see there CPAP, nasal CPAP, dose CPAP, oxygen therapy. These are basically non-invasive modes. And the upside is control mandatory ventilation, assist ventilation, SIMV plus PSV and PSV. These are basically the invasive modes which we can give in the patients. Depending upon the modes, there are the control panel. There are the parameters which we can control, like the flow, trigger, I time, E time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen, and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume or flow. So one by one I'll tell you what settings which we are needed to set for different parameters.
So this is an example of two ventilators. One was PM cares and one was neonatal ventilator. And we may find differences in various ventilator, and if we are not able to connect these pipes, this breathing circuit, we can ask the technician to show us how to connect the breathing circuit. So thank you very much. I think there are no questions.
Thank you, Dr. Manisha, for this excellent presentation. And I can see you have already answered the question. There was one question. So thank you very much.
Thank you.
So all these children who are on mechanical ventilation, they need a lot of monitoring, including blood pressure, SpO2 monitoring, and they need to be strictly monitored. So Dr. Anupma Verma is going to tell us about the multi-para monitor and how to do monitoring. And Dr. Anupma Verma is from LLRM Medical College, Meerut. So I welcome you, Dr. Anupma.
Thank you, ma'am. Thank you. Good afternoon, ma'am. Good afternoon to all the panelists and all the attendees. For the next 30 to 40 minutes, we will be talking about the multi-para monitor. It is such a common topic. We all will be using multi-para monitor in our ICUs, PICUs. But the basic knowledge, sometimes we lack the basic knowledge. So we should have some basic knowledge about the multi-para monitor. Okay. What are our learning objectives? Our learning objectives will be different monitoring parameters, how to use it, what should be our alarm setting, and what should be the maintenance of our multi-para monitors. First of all, what is multi-para? Multi-para is simultaneously measure and display of relevant vital parameters in a sick child. It simultaneously measure and display either in numeric value or there is a graph of the parameter. In general, basic models are used to monitor cardiac activity like ECG, heart rate, saturation, invasive and non-invasive blood pressure, respiration, and temperature. It consists of 4 components. First is sensor part, which is attached to your body. Then there is a communication link, followed by there is a processing device, and there is a display. Display either in number or in graphic presentation. Additional specifications are according to the model and maker, and there are multiple brands available in the market, like Milray, Philips, Drager. What is more important, you rather than going for the higher and higher model, we should know our machine. जो भी हमारे पास available है, जो भी हमारे ICU, PICU में set है machine, एटलीस्ट उसका हमें एक आइडिया होना चाहिए और उससे मैक्सिमम हम बेनिफिट्स ले सके, हम मैक्सिमम पैरामीटर्स उसे डिराइव कर सके, समझ सके. दैट इज मोर इम्पोर्टेंट. What should be our monitoring domains? In cardiology, we have ECG, cardiac output, continuous cardiac output, impedance cardiography. In hemodynamic oxygenation, we have invasive and non-invasive blood pressure, central venous oxygen, SpO2, and perfusion index. For airway and lung mechanics, we have respiratory mechanics. For tissue, perfusion, we have regional saturation. For neurology, we have EEG, NMT, and temperature. We will be taking up a few parameters in the next few slides. Red ones are the common parameters which we will be taking up. These parameters are ECG, respiratory rate, saturation, temperature, blood pressure, central venous, ETCO2, and other less common use parameters are EEG, regional oxygen saturation, cardiac output, continuous cardiac output monitoring, central venous oxygen saturation, neuromuscular transmission, impedance cardiography, bispectral index, and respiratory mechanics. First of all, the most common one is the ECG one. ECG lead सब लोग लगाते हैं, सब लोग monitor करते हैं हम लोग. तो either we can use 3 lead, 5 lead, 6 lead or 12 lead. जो भी हमारी ease है use करने की, उसके accordingly leads use करनी है. And we get heart rate derived from this ECG and saturation. Arrhythmia detection is very easy. Just by looking at the graph, हम बहुत सारे arrhythmias detect कर सकते हैं. In fact, we can diagnose many electrolyte imbalances just by looking at the graph of ECG. At least 3 lead electrode placement आना चाहिए हम सबको. 3 lead electrode placement में 3 electrode लगाने हैं body में. तो कोई भी patient को जब भी emergency में आता है, at least 3 lead उसे लगा के उसके attach कर दीजिए. तो at least basic जो rhythm है वो आपके monitor पे आना शुरू हो जाएगी. तो ये जो 3 leads लगानी है वो कहाँ पे? इसमें 3 होती है LA, RA and LL. LA is just below the left clavicle near the left shoulder. RA is lead, it is on the right side, just below the right clavicle near the right shoulder, and LL is in left lower above the abdomen. तो 3 लीड की प्लेसमेंट बिल्कुल रिफ्लेक्स में होना चाहिए हमारे. तो ये लीड लगाया और एक आपने अटैच करा ECG लीड को मॉनिटर से, और आपका एक बेसिक रिदम जो नीचे दिखाई दे रहा है, बेसिक रिदम along with the heart rate डिस्प्ले होने लग जाएगी हमारे मॉनिटर पे. एंड आवर मॉनिटरिंग स्टार्ट्स राइट फ्रॉम देयर. Next important component is the respiratory rate monitoring. Respiratory rate monitoring is derived from CO2 monitoring or by the impedance. Impedance same ECG leads जो हमने 3 leads लगाई हैं उसी को ही उसके ही impedance से आपका respiratory rate monitor होगा और display होगा आपके monitor पे. 59 is the respiratory rate and this is rhythm of respiratory rate. Either lead 1 or lead 2 is used for the respiratory rate monitoring. Lead 1 क्या होती है? Lead 1 is a line connecting the LA and RA, जो दोनों ऊपर वाली लाइन है वो that is lead 1. Lead 2 is line connecting RA and LL. Either of the lead can be used for monitoring the respiratory rate. Next important parameter which we monitor is pulse oximetry. It is the most talked about in the COVID era. Even the layman knows कि pulse oxygen saturation कितना चल रहा है. So this is the most common parameter. It consists of 4 components: SpO2, perfusion index, plethysmography variability index, and signal IQ indicator. We will be taking up one by one and understand this parameter. This pictorial representation of the various SpO2 monitors. SpO2 this clips available in the market. तो तरह का होता है, clips होती हैं. Either there is a band form, band आप attach कर सकते हैं to the peripheries of your body. या फिर एक ये क्लच के फॉर्म में होता है. तो various sensors are available in the market for the SpO2 monitoring. First of all, SpO2. What is SpO2? It measures the oxygen saturation. Oxygen saturation कितना है? Target saturation जो होगा pediatric age group में, it will be 92, which is different from adult. In adult, we were taking 94 as target saturation, but in pediatric age group, we will be taking target saturation as 92. At the same time, we should avoid hyperoxemia in newborns. So newborns में basically आपका hyperoxemia is more detrimental to the newborns. तो बहुत ही आपको value titrate करनी है. The saturation should be between this 88 to 92. There should be a numeric and graphic display of saturation, and probe placement should be in the right upper hand in neonates. So pre-ductal बोलते हैं इसको. Right upper hand में आपका probe attach होगा. And we should avoid attaching the probe in the limb in which the BP is being measured. So in between, जैसे जैसे bladder inflate होता है, there is occlusion in the artery और unnecessary आपकी false reading display होगी उस पे monitor पे. तो जिस हाथ में हम BP कब बांधेंगे उस हाथ में आप probe नहीं attach करेंगे. Changing of probe site is very important, and ear probes are also available in the market. बेसिकली वहां पे यूज होते हैं जहां पे आपका पेरिफेरल परफ्यूजन बहुत ज्यादा पुअर है और आपकी रीडिंग नहीं आ पा रही है. तो ear probes can be used in this patient in which the peripheral perfusion is very poor. Next parameter is perfusion index and plethysmography variability index. Perfusion index क्या है? It is an indicator of peripheral blood flow. आपकी पेरिफेरी में कितना ब्लड फ्लो हो रहा है, that is depicted by the perfusion index value. It measures the strength of photoplethysmography signal at the sensor site. Actually it is a ratio of pulsatile to non-pulsatile, और वैल्यू जो रेंज करेगी दैट इट रेंजेस फ्रॉम 0.02 to 20%. 0.02 अगर पीआई है तो दैट मीन्स इट इज अ वेरी वीक पल्स स्ट्रेंथ. 20% अगर पीआई है दैट मीन्स वेरी स्ट्रॉन्ग पल्स स्ट्रेंथ इज देयर. तो जैसे मॉनिटर में है 1.1, दिस इज परफ्यूजन इंडेक्स विच इज डिपिक्टेड इन द मॉनिटर. What is plethysmography variability index? It is actually the change of perfusion index during a respiratory cycle. Respiratory cycle में जो perfusion index में change आ रहा है वो जो study होती है that is perfusion variability index. It is derived from the value of maximum perfusion index maximum minus minimum upon maximum multiplied by 100. और बेसिकली ये हम कहाँ यूज करेंगे? आप वॉल्यूम स्टेटस इन कार्डिक पेशेंट में फर्दर फ्लूइड बोलोसिस देने हैं या कोई पेशेंट कार्डिक सर्जरी के है तो थोड़ा सा ये है फॉर क्रिटिकल मॉनिटरिंग पेशेंट में आपका परफ्यूजन वेरिएबिलिटी इंडेक्स यूज होता है. परफ्यूजन वेरिएबिलिटी इंडेक्स मोर देन 14% शोज रिस्पांस टू द फ्लूइड फ्लो. Second, last component in this saturation is SIQ. What is SIQ? SIQ is signal IQ indicator. Basically जो strength है, पल्स है, पल्स की जो स्ट्रेंथ है जिससे आपका सेंसर रीड कर रहा है और फाइनली एक वैल्यू आपको डिस्प्ले कर रहा है, जो स्ट्रेंथ आ रही है पल्स की वो एडिक्वेट है या नहीं है, दैट इज डिपिक्टेड बाय द सिग्नल आईक्यू इंडिकेटर. इट इज बेसिकली द क्वालिटी ऑफ फ्लो टू द एरिया अप्लाइड एंड हेंस द सिग्नल क्वालिटी. तो अगर आपका सिग्नल अच्छा है, आपकी जो पेरिफेरल पल्स है वो अच्छे से रीड कर रहा है, सिग्नल अच्छे से ले रहा है, तो वैल्यू जो होगी दैट आर ट्रू वैल्यूज. पर इन केस अगर देयर इज वेरिएबिलिटी इन दिस सिग्नल, पल्स आपकी बहुत वीक है या इररेगुलर पल्स है तो आपका सिग्नल बहुत ही वीक है, तो उससे तो दिस सिग्नल स्ट्रेंथ इज डिपिक्टेड ऑन द मॉनिटर. इट इज डिपिक्टेड बाय ये जो रेड सर्कल है इसमें ये सिग्नल आईक्यू इंडिकेटर है. इसमें बेसिकली एक हॉरिजॉन्टल लाइन होती है and there are multiple vertical lines. Each vertical line depicts a arterial impulse. एक impulse पे एक vertical line आएगी, फिर impulse आएगी आपकी, फिर उस पे एक vertical line. तो this is how it is shown on the monitors. We will take a few example to understand better. जैसे ये 4 example है. सबसे पहले वाला लेते हैं. There is सबसे पहले नीचे देखते हैं. नीचे is there is a vertical, this is horizontal line in between vertical regular intervals पे है. तो दिस इज गुड सिग्नल आईक्यू इंडिकेटर. ऐसे ही हमने पहले वाले एग्जांपल में देखा था. तो दिस इज अब हमारा सिग्नल इंडिकेटर है वो बिल्कुल सही है एंड देयर इज वेव फॉर्म इज गुड प्लेथिस्मोग्राफी. तो वैल्यू जो डिपिक्ट हो रही है दैट इज 95, 1.06, 179. तो ये दीज वैल्यूज में बी ट्रू वैल्यूज. तो ये हम दीज आर इंपॉर्टेंट वैल्यूज. तो आवर इन्फ्रेंस इज गुड SIQ along with good plethysmography. नेक्स्ट सेकंड वाला देखते हैं. सेकंड वाले में क्या? देयर इज अ हॉरिजॉन्टल लाइन एंड देयर इज एब्सेंट वर्टिकल लाइंस. तो वेरी पुअर सिग्नल आईक्यू इंडिकेटर along with there is variable plethysmography. तो जो वैल्यू हमारे मॉनिटर पे आ रही है दे मे बी फॉल्स वैल्यू. वी शुड चेक इट अगेन. मतलब वो कुछ प्रॉब्लम हो सकती है, आपका सिग्नल ठीक नहीं आ रहा है पेशेंट में. तो आवर इन्फ्रेंस इज पुअर SIQ along with इनकंक्लूसिव प्लेथिस्मोग्राफी. थर्ड वाले में देखते हैं. थर्ड वाले में ठीक है, एक हॉरिजॉन्टल लाइन है, वर्टिकल लाइंस है, तो वी हैव गुड सिग्नल आईक्यू इंडिकेटर along with this irregular plethysmography. So our inference will be good signal IQ indicator along with variable plethysmography. लास्ट वाला देखते हैं. लास्ट वाले में सिग्नल IQ इंडिकेटर इज वेरी गुड. बिल्कुल ठीक है. एक हॉरिजॉन्टल लाइन है इन बिटवीन वर्टिकल लाइंस और रेगुलर इंटरवल पे, तो हर इंपल्स को वो रीड कर रहा है. बस प्रॉब्लम कहाँ है? जो प्लेथिस्मोग्राफी दैट इज लो वॉल्यूम. तो आवर इन्फ्रेंस इज गुड SIQ along with non-variable low volume plethysmography. Next important parameter which we will be looking in our multi-para monitor is temperature. Temperature is thermally sensitive resistors are used. The resistance change of thermistors are used to calculate the temperature and up to 2 temperature sites. एक साथ आप 2 temperature sites को monitor कर सकते हैं and the difference between the 2 sites is calculated. Rectal temperature monitoring is also possible with spatial probes. इसके लिए अलग से probes आते हैं and basically सब patient में नहीं, severe acute malnutrition है, severe hypothermia है, उन patients में हम rectal temperature monitoring करते हैं. Next important parameter is blood pressure monitoring. Blood pressure monitoring is done by 2 methods, invasive and non-invasive. तो सबसे पहले non-invasive blood pressure monitoring. It is taken up by the oscillometric method. बेसिकली आपका जो आर्टेरियल इम्पल्स है ऑसिलेशंस प्रोड्यूस करती है आपकी आर्टेरियल वॉल में. These oscillations are picked up by the sensor and depicted in the value of blood pressure. तो जब भी नॉन इन्वेजिव ब्लड प्रेशर आप ऑसिलोमेट्री मेथड से लेंगे तो देयर आर 3 वैल्यूज. एक सिस्टोलिक ब्लड प्रेशर की वैल्यू होती है, एक डायस्टोलिक ब्लड प्रेशर की वैल्यू होती है और एक मीन ब्लड प्रेशर की वैल्यू होती है. जो एक्चुअली मेजर करता है बाय द ऑसिलेटरी मेथड से, ऑसिलेशन से, वो मीन ब्लड प्रेशर मेजर करेगा. And systolic and diastolic blood pressure values are derived from the mean blood pressure. Some important points while taking BP. This is first of all जो सबसे ज्यादा important है कि आपका जो कफ साइज यूज करें that is appropriate. बिल्कुल सही साइज का होना चाहिए. बड़ा कफ यूज करेंगे तो हमारा बीपी कम आ सकता है, छोटा कफ यूज करेंगे तो बीपी हमारा बड़ा हुआ आ सकता है. तो हम बीपी कफ कैसे डिटरमाइन करेंगे कि अप्रोप्रिएट साइज का नहीं है. फर्स्ट ऑफ ऑल डिटरमाइन द लिम्ब सर्कमफ्रेंस, दैट इज द मिड पॉइंट बिटवीन द एक्रोमियन एंड द ओलिक्रॉन प्रोसेस के बीच का मिड पॉइंट होती है, मिड पॉइंट लेना है. एंड दैट विड्थ ऑफ द कफ शुड बी 40% इन यूनिट्स एंड 2/3 इन द ऑफ द लेंथ ऑफ द अपर आर्म और थाई इन चिल्ड्रन. द इन्फ्लेटेबल पोर्शन, जो ब्लैडर पार्ट होता है जो कफ का, दैट शुड कवर 60 to 80% ऑफ द कफ. तो ये अगर दोनों पॉइंट्स हम ध्यान रखेंगे तो हमारा कफ विल बी ऑफ एप्रोप्रिएट साइज. Application of cuff should be such that the RT marking should be at appropriate place. एक ज्यादातर कफ पे ना एरो बना होता है, that should be on the artery. जो आर्टरी है वहीं पे रहना चाहिए उस पोजीशन पे. It should be smooth and snugly fitting. तो बहुत ज्यादा टाइट कफ नहीं बांधना है आपको, बहुत लूज भी कफ नहीं रखना है. And we should choose an auto deflation mode. Ideally, average of 3 readings should be done. And we should avoid taking BP in crying and agitated child. बेसिकली उस टाइम में आपका बीपी बढ़ा हुआ आ सकता है. देयर में बी फॉल्स रीडिंग इन क्राइंग एंड एजिटेटेड चाइल्ड. तो दीज आर द वेरियस बीपी कफ्स अवेलेबल इन न्यूनेटल बीपी, डिस्पोजेबल न्यूनेटल बीपी कफ्स अवेलेबल इन द मार्केट. अलग अलग साइजेस के होते हैं. सबसे छोटा साइज जो है दैट इज साइज 1, 2, 3. सबसे बड़ा वाला जो कफ होता है दैट इज साइज 5. नेक्स्ट इज इन्वेजिव ब्लड प्रेशर. इन्वेजिव ब्लड प्रेशर मॉनिटरिंग के लिए आपको बेसिकली इंट्रा आर्टेरियल लाइन चाहिए. तो इट इज नॉट जनरली यूज्ड. इट इज यूज्ड ओनली इन क्रिटिकली इल पेशेंट्स, रियल टाइम, वेयर रियल टाइम रिकॉर्डिंग इज रिक्वायर्ड, एंड वी गेट बोथ न्यूमेरिक एंड वेव फॉर्म्स इन द इन्वेजिव ब्लड प्रेशर. कैसा होता है? बेसिकली आर्म है, इंट्रा आर्टेरियल लाइन होती है. इंट्रा आर्टेरियल लाइन से 5 नंबर दैट इज दिस इज 3-way valve अटैच होता है. 3-way valve इज अटैच्ड टू अगेन एक 3-way valve. And then it is connected to transducer. Number 4 is transducer. Transducer is then connected to through IB cable. एक cable होता है, 3 number is IB cable, and then it is connected to module, and module is fitted in our multi-para monitor. तो अलग अलग पैरामीटर्स के अलग अलग मॉड्यूल्स होते हैं, वो आपके मल्टीपैरा में फिट लगे हुए होते हैं. And there is one pressure bag. It is filled with normal saline. Number 1 is this pressure bag. ये उसका पिक्चर है. दिस इज प्रेशर बैग फिल्ड विद नॉर्मल सलाइन कनेक्टेड टू IV line. IV line is connected to transducer. Then it is connected to cable. Red part, this is cable, and which will be attaching to the module. What are the important points of taking the invasive blood pressure? We should, for the patency, we will be soft tubing of bag of NaCl or 500 plus solution. Sorry. There is a soft tubing of bag of NaCl containing non-500 ml plus solution should be placed in a pressure bag, and it should be inflated to 300 millimeter of mercury. Leveling is very important to minimize the effect of hydrostatic pressure on a transducer. If it is too high, it will create lower pressure and abnormally low pressure will be there. If it is too low, greater pressure will be there and abnormally high pressure value will be there. Zeroing is done to negate influence of external pressure on monitoring system. What are the components of the arterial waveform? There are 4 components of waveform. Number 1 is systolic blood pressure. Number 3 is diastolic blood pressure. और बीच में number 3 जो है, number 2 जो है, that is dichrotic notch. Last parameter which we will be talking today is EtCO2, and for me it is the most important one. बिकॉज जितने भी अभी तक पैरामीटर्स हमने पढ़े थे उसका एक बेसिक नॉलेज है हमको, और वो यूज भी कर रहे हैं हम लोग कोविड एरा में। EtCO2 कहीं जगह यूज होता है पर कहीं जगह नहीं होता है, यूज हो रहा है। तो व्हाट इज EtCO2? जो हम सैचुरेशन पढ़ते हैं SpO2 है, वो बेसिकली आपका ऑक्सीजनेशन वैल्यू बताता है कि बॉडी में ऑक्सीजन लेवल कितना है। What EtCO2 value depicts? It depicts actually the ventilation part. तो आर्ट्रियल एल्वुलर एक्सचेंज है ना, माइक्रोस्कोपिक लंग्स के एल्वुलर लेवल पे बात करें तो एल्वुलर आर्ट्रियल एक्सचेंज कितना हो रहा है, वो उसमें प्रॉब्लम तो नहीं है, दैट इज डिपिक्टेड बाय द EtCO2 वैल्यू। इफ देयर इज वेंटिलेशन इज हैम्पर्ड, तो सैचुरेशन फॉल होने में कुछ मिनट्स लगेंगे, 1 to 2 मिनट्स के बाद आपका सैचुरेशन वैल्यू फॉल करेगी। पर अगर आप EtCO2 मॉनिटर कर रहे हैं तो विद इन फ्यू सेकेंड्स EtCO2 वैल्यू में चेंज आ जाएगा जैसे आपका वेंटिलेशन पार्ट हैम्पर होगा। तो EtCO2 इज अ मोर सेंसिटिव मार्कर for the ventilation part. What is capnography? It is a graphic display of CO2 concentration versus time. इसे time capnography बोलेंगे, and when it is studied against the expired volume, it will be called as volume capnography during a respiratory cycle. Capnograph is a machine that generates a waveform and capnogram is the actual waveform. तो हम आगे देखेंगे next slides में capnogram आएगा। तो जो waveform create होता है that is called as capnogram. This is how the CO2 is produced by the molecular oxygenation. जो level है cellular level पे CO2 produce होती है, it is taken up by the circulation. Circulation से finally it is taken up by the lungs and lungs से finally आपकी बाहर आती है CO2. And this is capnogram. Capnogram का ऐसा ग्राफ दिखेगा. This is a normal capnogram with along with the EtCO2 value of 34 and this is 15 is respiratory rate of the patient. सेंसर कैसे अटैच करना है? दो तरह से आप सेंसर अटैच कर सकते हो EtCO2 का, या तो आप डायरेक्टली ET ट्यूब में उसे अटैच कर दीजिए, दैट इज कॉल्ड एज मेन स्ट्रीम मॉनिटरिंग, या आप अडेप्टर के थ्रू से साइड स्ट्रीम पे भी अटैच कर सकते हैं, दैट इज कॉल्ड एज साइड स्ट्रीम मॉनिटरिंग। तो आइदर ऑफ द टू कैन बी यूज्ड फॉर द EtCO2 मॉनिटरिंग। हाउ इट लुक्स लाइक, कैप्नोग्राम नॉर्मली कैसा होता है कि इस तरह का आपका जो ग्राफ होता है वो दिखता है हमें उस पे अपने स्क्रीन पे। इसमें दो कंपोनेंट्स हैं सॉरी, एक व्हाइट पार्ट है, एक येलो पार्ट है। येलो पार्ट इज द एक्सपिरेशन पार्ट एंड व्हाइट पार्ट इज द इंस्पिरेशन पार्ट, अगर ये आप डिफरेंशिएट कर पा रहे हैं। तो सबसे पहले फेज 1 देखते हैं। एक बेसिक आइडिया से, एक्चुअली ये देखना इसलिए इंपॉर्टेंट है कि आप ना सिर्फ अगर आप ग्राफ भी मॉनिटर कर रहे हैं तो बहुत सारे हम अर्ली साइंस सिर्फ ग्राफ के वैल्यू पे हम बहुत सारी चीजें डायग्नोस कर सकते हैं। तो जस्ट एक बेसिक आइडिया और हम फिर उसके एग्जांपल्स पढ़ेंगे फॉर द बेटर अंडरस्टैंडिंग। तो सबसे पहले फेज 1, देयर इज एंड ऑफ इंस्पिरेशन, जहां व्हाइट खत्म हुआ और येलो स्टार्ट हुआ, दैट इज स्टार्ट ऑफ एक्सपिरेशन पार्ट। तो इनिशियली आपका डेड स्पेस की क्लियरिंग होती है, तो CO2 नहीं होता है वहां पे, डेड स्पेसेस वेयर नो गैस एक्सचेंजेस देयर, तो वहां पे CO2 नहीं है, तो देयर इज फ्लैट कर्व। तो आपका फेज 1 इज फ्लैट 1। फिर फेज 2 में क्या होगा, देयर इज अ रैपिड राइज ऑफ CO2 as the air from the alveoli containing the CO2 reaches the upper airway, जहां पे आप सेंसर अटैच है आपका upper airway के पास, तो जितना CO2 है alveoli का वो सारा बाहर आता है, तो there is a rapid increase in the this phase. Then there is a phase 3, there is it is called as alveolar plateau. तो CO2 जितनी आनी थी alveoli से वो सब आ चुकी है, तो मैक्सिमम वैल्यू पे वो पहुंच गया है। एंड द एक्चुअली एक और आप इससे आइडिया निकाल सकते हैं, जो हाइट इस प्लेट्यू पे ही है, दैट डिपिक्ट्स द कार्डिक आउटपुट। तो हम कार्डिक आउटपुट का भी असेसमेंट देख सकते हैं जस्ट बाय लुकिंग एट द हाइट, ये प्लेट्यू का कितना हाइट है। छोटा हाइट है तो आपका कार्डिक आउटपुट कम चल रहा है, अगर अप्रोप्रिएट हाइट है दैट इज आपका कार्डिक आउटपुट पेशेंट का बिल्कुल ठीक है। देन देयर इज दिस ब्लू सर्कल इज एंड टाइडल, जहां पे टाइडल एंड कर रहा है वहां का CO2 रीडिंग, दिस वैल्यू इज टेकन बाय द सेंसर एंड विल शो ऑन योर मॉनिटर। तो EtCO2 का वैल्यू इज दैट इज द एंड ऑफ एक्सपिरेशन एंड स्टार्टिंग ऑफ इंस्पिरेशन, तो दिस वैल्यू विल बी टेकन अप बाय द सेंसर। तो यहाँ पे जैसे ही इंस्पिरेशन स्टार्ट हुआ, व्हाइट पार्ट जो स्टार्ट हो रहा है दैट इज एंड ऑफ एक्सपिरेशन एंड स्टार्टिंग ऑफ इंस्पिरेशन, तो there is a rapid decrease in CO2 and inspiration clears, all the CO2 is cleared. This is called as phase 0. अब ये कुछ एग्जांपल्स हैं फॉर द ऑफ एबनॉर्मल कैप्नोग्राम फॉर द बेटर अंडरस्टैंडिंग। सबसे पहले वाला देखते हैं। इसमें क्या है, पहला वेव बिल्कुल ठीक है, दूसरा वेव बिल्कुल ठीक है, फिर उसके बाद वेव ही नहीं आई है हमारी। तो वेव नहीं आई, इसका मतलब क्या है कि CO2 नहीं आ रहा, हमारा सेंसर्स में CO2 नहीं पहुंच रहा। तो आइदर देयर इज ET ट्यूब इज डिस्कनेक्टेड, डिसलॉज और किंक, ET ट्यूब भी आपकी हट गई है, और या एम्पलीट्यूड नहीं आ रहा आपका, प्लेट्यू का जो हमने एम्पलीट्यूड देखा वो नहीं है, तो देयर इज लॉस ऑफ सर्कुलेटरी फंक्शन. तो आइदर ऑफ दीज प्रोड्यूस दिस टाइप ऑफ कैप्नोग्राम. सेकेंड एग्जाम्पल देखते हैं. सेकेंड एग्जाम्पल में क्या है, द फर्स्ट वेव इज नॉर्मल कैप्नोग्राम एंड देयर इज डिक्रीज इन दिस. थोड़ा कम हुआ, थोड़ा कम हुआ, तो आपकी CO2 आ तो रही है कुछ सेंसर पे, पर कुछ है प्रॉब्लम. तो क्या है प्रॉब्लम? ET ट्यूब या तो लीक कर रही है, आइदर द ET ट्यूब इज इन हाइपोफेरिंक्स और देयर इज पार्शियल ऑब्स्ट्रक्शन ऑफ ET ट्यूब. तो जस्ट बस एक ग्राफ देख रहे हैं हम, ये वो कर सकते हैं कि हाँ CO2 नहीं आ रहा, तो आइडल या तो ट्यूब ब्लॉक है या डिस्प्लेस्ड. थर्ड एग्जाम्पल देखते हैं. थर्ड एग्जाम्पल में ठीक है, कैप्नोग्राम में राइज तो आ रहा है, बट जो हम बोलते हैं एटलीस्ट 35 to 45 का जो एम्पलीट्यूड होना चाहिए वो नहीं आ रहा है. तो बेसिकली दिस इज ड्यूरिंग द CPR असेसमेंट. CPR असेसमेंट में अगर आपका एटलीस्ट 10 मिलीमीटर का अगर राइज आ रहा है प्लेट्यू का, दैट इज वी आर डूइंग इफेक्टिव दिस चेस्ट कंप्रेशन. तो वी कैन हैव असेसमेंट ऑफ CPR जस्ट बाय लुकिंग एट द कैप्नोग्राम. लास्ट फर्स्ट रो में लास्ट वाला देखते हैं. ठीक है, ये कैप्नोग्राम है, ये कैप्नोग्राम है, एकदम से ये बढ़कर आया. व्हाट इज दिस? इट इज रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन. किसी भी वजह से अगर पेशेंट वेंटिलेटेड है, डीपली सेडेटेड है, अगर उसका रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन होगा तो देयर इज अ रैपिड इंक्रीज इन CO2 एंड इट इज डिपिक्टेड बाय दिस ROSC बोलते हैं इसे, रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन. और सेकंड कॉलम में फर्स्ट वाला है, दैट इज शार्क पेन अपीयरेंस, बिल्कुल शार्क के फिन के जैसा है. दिस इज टिपिकल ऑफ एस्मा एंड COPD. उसके बाद देयर इज डिक्रीज इन फ्रीक्वेंसी व्हिच इज सीन इन हाइपोवेंटिलेशन केस, इंक्रीज इन फ्रीक्वेंसी व्हिच इज सीन इन हाइपरवेंटिलेशन केस. सबसे लास्ट वाला देखते हैं. पहला वाला कैप्नोग्राम नॉर्मल, फिर उसके बाद थोड़ा CO2 कम हो गया और कम हो गया और ये पॉज में चला गया, फिर एकदम से बढ़ गया. तो दैट इज सीन इन आइदर इन एपनिया और इन डीपली सेडेटेड पेशेंट. होप कि कुछ थोड़ा सा एक बेसिक आइडिया हो सबको ना कैप्नोग्राम का. Next important component of using multipara monitor is setting up of alarms. जो भी हमारे alarms होते हैं उनका भी use करना actually हम लोगों को आना चाहिए. तो दो तरह के alarms हमारे multipara monitors में होते हैं. There is audio alarm and there is visual alarms. Audio तरह के sounds आते हैं, beep आवाज आएगी. विजुअल साउंड्स होते हैं कि पहले लाइट जो है ग्रीन ब्लिंक करती है, येलो ब्लिंक करती है, रेड ब्लिंक करती है, ऑरेंज करती है. तो वी शुड ऑलवेज सेट आवर अलार्म्स. जो भी पेशेंट जब भी प्लेस करेंगे हम उस ICU बेड पे, उसका मल्टीपारा मॉनिटर अटैच करेंगे, फिर उस जैसे अटैच कर देते हैं मॉनिटर, तो हमारा पहला काम ये होना चाहिए उसके अकॉर्डिंगली जो पेशेंट है, एज है, सेक्स है पेशेंट का, उसके अकॉर्डिंगली हमें हार्ट रेट, रेस्पिरेटरी रेट, जो भी उसका नॉर्मल रेंज ऑफ हार्ट रेट है, नॉर्मल रेंज ऑफ रेस्पिरेटरी रेट है, नॉर्मल रेंज ऑफ BP है, जो हमें उसका टारगेट सैचुरेशन रखना है, टेम्परेचर रखना है, या इरिथमिया के, हमें अलार्म्स पहले से ही सेट कर देने चाहिए. Unnecessary alarm should be avoided in ICU क्योंकि that is also detrimental for this sick patients. और एक्चुअल में यूज भी कि हम पूरे टाइम उसे बिल्कुल उसमें साइलेंट मोड पर कर दें तो कोई फायदा ही नहीं है आपके अलार्म यूज करने में. तो अलार्म्स यूज करने भी आने चाहिए हमें विद मल्टीपैरा मॉनिटर्स. नेक्स्ट इंपॉर्टेंट कंपोनेंट ऑफ यूजिंग एनी मशीन, वो आप कोई भी मशीन हो, चाहे आपका वेंटिलेटर हो, चाहे आपका मल्टीपैरा मॉनिटर हो, दैट इज मेंटेनेंस ऑफ द मशीन. क्योंकि गवर्नमेंट सेटअप पे एक मशीन के लिए एक्चुअली बहुत मेहनत करनी पड़ती है. तो वी शुड बी रिस्पॉन्सिबल, वी शुड मतलब अपनी मशीन की तरह, और वी शुड हैव ओनरशिप ऑफ दिस मशीन ऑल्सो. एक्सटेंशन केबल शुड बी टक्ड इन अ बैग व्हेन नॉट इन यूज, वेरी इंपॉर्टेंट. कई बार क्या होता है कि पेशेंट इधर से उधर शिफ्ट करा और एक्सटेंशन केबल आपका इधर गिरा है, उधर गिरा है, तो इट शुड नॉट बी डन. Disposable accessories should be used as much as possible, and we should use reusable accessories as much as possible, and it should be cleaned with this split swab in between. And accessory when not in use should be kept in a labeled box. सबसे ज्यादा जो wear and tear होता है that is the sensor जो होता है मल्टीपैरा मॉनिटर का, जो हम पेशेंट में अटैच करते हैं, सबसे पहले वही खराब होता है. तो उसमें यही है कि जब भी यूज नहीं हो रहा है आपका, तो हमेशा एयर टाइट कंटेनर में विथ लेबल कि ये मल्टीपैरा मॉनिटर का हमारा सेंसर रखा हुआ है, इट शुड बी प्लेस्ड इन दिस एयर टाइट कंटेनर व्हेन नॉट इन यूज. तो दिस इज आल्सो इम्पोर्टेंट फॉर यूजिंग एनी मशीन. Key messages of my presentation is real-time monitoring of all parameters is very important. We should use sensor properly. Always set age-appropriate alarms. क्योंकि pediatric में यही है कि आपके age, patient के age, patient के sex पे हमारा BP, heart rate, हर एक की value अलग-अलग होती है. Early warning of adverse changes and trend should be seen. Response to therapeutic intervention should be taken care of. We should reflect proper functioning of other equipment too. These are the references for detailed study. If one is interested, can go to this references. Skills to be learned are various. We should understand various parameters. We should able to identify compatible and appropriate sensors. We should identify and interpret abnormalities and setting up the alarm limits. This is my last slide and my favorite one and the most important one according to me. The most important monitor is not the machine, it is clinician. We are the best monitor. We should always remain vigilant, integrate monitor information into patient care rather blindly following the numbers. आग बंद करके numbers के पीछे नहीं भागना है, हमेशा हमारा clinical sense at par होना चाहिए. आपके जो भी नंबर या आपका वेव फॉर्म आ रहा है मल्टी पैरा मॉनिटर. My sincere thanks to all the contributors and my sincere thanks to my Chandrakanta ma'am and Dr. Shelly Avasthi ma'am. In the end, I have 3 videos of this ECG, BP and ETCO2.
For the blood pressure monitoring of patient, we have this non-invasive blood pressure monitoring NIBP cable with the one end attached to the module and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and the cuff to the baby, we will start measuring of blood pressure by pressing the knob or the touching the screen. That option is available in the monitor. And frequency of measurement of blood pressure is can be manually or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours, that automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end the blood pressure with systolic, diastolic and mean will appear on the monitor. In this baby the blood pressure is the higher range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic and mean blood pressure.
Second video is about the this ECG monitoring.
ECG cable has also 2 parts. One is the connecting cable and second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3 lead ECG with the left part, right part and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor, and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or a arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you.
Last video is about the ETCO2 monitoring.
For the end tidal CO2 monitoring, we have a separate micro stream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this version 19, we have a separate module that put into the satellite unit, and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, ETCO2 number will display on the monitor, and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby.
That's all from my side, ma'am.
Thank you, Dr. Anupama, for this excellent presentation.
Thank you,
And
ma'am.
there is only one question for you. So there is question where we see capnogram on the monitor.
Capnogram, the waveform is displayed on the monitor only.
Displayed on the monitor,
Monitor,
actually, but
yes.
we should have that type of monitor actually,
Yes, ma'am.
which have facility.
Facility of this.
Capnograph.
Yes, ma'am.
Okay. Thank you, Dr. Anupama.
Thank you, ma'am. Thank
Most of the places we don't have that facility with the monitors. It is only the
Yes, sir.
high-end multi-monitors that may be having. So it's more important to know basically, and then they can search for their.
Yeah.
Yes.
Okay. So welcome, Dr. Thapar, sir.
Thank you, ma'am. Thank you.
So for the next talk, I invite Dr. R.K. Thapar, sir. Sir is currently working at Sharda Hospital, Noida, and he will be teaching us about the indications of mechanical ventilation and the modes of mechanical ventilation. Welcome,
Thank you. Thank you, ma'am. I'll just share my slides. Huh?
Yes, sir.
Okay. Share. Is it visible, ma'am? I'm audible and visible,
Yes, sir.
ma'am?
Yes, sir.
Yeah. Okay.
Yes, sir.
Thank you so much, Chandrakanta, ma'am. After a gap of 2 weeks, we are back
Yes, sir.
on
Missed you.
on this COVID pediatric preparation.
Yes,
So I welcome all my participants and I wish them great success. So we have moved from day 1, day 2 to day 3. Basically today we'll all be discussing about how to use the ventilation, modes of ventilation, indications, monitoring, extubation, and the titration, how the patients as we go forward. So my talk will be only limited to indications and modes of ventilation. In the next 35 minutes before your lunch, I hope we should be able to have some idea about various things, indications and modes of ventilation. We assume that most of you must have seen in your institutions, you have worked with them, ventilators, you must have ventilated the babies. So take it as a just a refreshing of your knowledge and maybe a little getting oriented to the pediatric component for those who are non-pediatric participants. So at the end of talk, we should be having some indications of learning objectives to be that we should have some idea about what are the indications of ventilation. Then a little background that what all causes respiratory failure, where can be the problems, and just to have some idea about various modes of which we see in a standard ventilator, and then how to choose the appropriate mode. So all of us are very well aware and we are very much confident that a normal respiration involves exhalation of carbon dioxide and inhalation of oxygen, because oxygen is essential for our various cellular metabolism activity. And as a result of that metabolism, carbon dioxide is produced, which has to be taken out from the lungs. So that is a basic premise of functioning of the normal lungs. Now, if any of things is not working, that means either there is a problem of oxygenation or there is a problem of carbon dioxide elimination. So both the criteria, if there are problems, then we can call it as that the respiration is failing or there is a respiratory failure. So far, so good. Now, now what could be the causes? Just a revision that the causes can be from the respiratory center onwards to the respiratory muscles. So it could be in the form of brain injury. The injury may be to the spinal cord, trauma, myelitis, then GV syndrome. As pediatricians or physicians, we are familiar with the condition. There's a neuropathies they can cause, leading to respiratory failure. There may be problem at the junction, neuromuscular junction. The problem may be in the muscle itself. We know spinal muscular atrophies and myopathies, which causes the respiratory failure because the muscles are not able to generate that much negative pressure. Then a common condition we see less frequently because of the good guidelines publication and implementation, that is asthma, narrowing of the airways, which may lead to ventilation related issues and causing respiratory failure, severe acute flare-ups basically. Then the present condition, which may lead to pneumonia, ARDS, pulmonary hemorrhage, that is the COVID pneumonias. So they involve the alveoli. So the problem is at the alveoli. So we have to think these various causes and apply that knowledge accordingly. Or there may be a problem in the cavity itself. It may be air in the cavity, there's a pneumothorax, or there may be fluid, pus, empyema. So broadly, there's a broad term of respiratory failure, which we must have a little idea about these things. Now, once we know what is respiratory failure, what are the causes of respiratory failure, then how to diagnose. So naturally, we should have some subjective criteria, some objective criteria. The criteria may be in the form of that the child is tachypneic, he is having breathing difficulty, he has got a nasal flare, which is very commonly seen, which we see in various respiratory conditions, retractions, the chest caving in, then there may be cyanosis, then initially the cardiovascular system tries to cope up in the form of tachycardia or hypertension, but subsequently, when the work of breathing increases too much, the bradycardia sets in and hypotension also sets in. Clinically, we may found some additional sounds, there may be absence of breath sounds. So these are the clinical findings which we generally encounter in such cases. And the investigation anytime, as last panelist has spoken about the SpO2, which is a common thing now, home world, that SpO2 kitna chal raha hai. So SpO2 requirement will tell us objectively that how much is the saturation. Then if we have got access to blood gas analysis, definitely critical care cases, sick patient, we do need ABG values, that if the PO2 is less than 60 and PCO2 is more than 50, so that qualifies as a diagnosis of respiratory failure. Then in the meantime, by the time patient has deteriorated from mild to moderate to severe condition, and we must have got the X-ray chest, or in some of the cases, maybe we could have got the CT scan done. So those findings will be helping us in reaching a diagnosis of respiratory failure. In the end, it is the work of breathing, which will take precedence, which will take for which we have to take a call, we have to take a decision. Then now the work of breathing, child may not be able to cope up with this much work of breathing, and he is getting tired, so we have to support. So that is the basic premise of going inside the lungs by putting endotracheal tube. So before we put the endotracheal tube, which there's another session on intubation. So let's plan out basically on a broader scale that what could be the treatment of respiratory failure. As you have learned, in mild to moderate cases, there may be only hypoxia. We may just get away with some oxygen therapy in the form of nasal prongs, maybe in the form of mask, or maybe non-rebreathing mask. And so there are various modalities available for oxygen therapy, giving FiO2 of 40, 60, 80% that we all have studied in the oxygen therapy. Okay. Now another situation may be that there is a hypoxia, but along with there is hypercarbia also. But so far, patient has got good spontaneous efforts. So this is another situation where we can get away with non-invasive ventilation. That is how your BiPAPs will come here. Maybe HFNC may also be, because we are not going inside the trachea. We are not putting the tube here. We are just limiting ourselves to CPAP, BiPAP, or maybe high frequency heated humidified nasal cannula, that is HFNC. So, but the requirement here is that patient has got spontaneous efforts. We can't put the NIV on a patient with poor respiratory efforts. So that clinical decision is ours, that we have to see that what is the condition. Now, the child has further deteriorated along with hypoxia, hypercarbia. Now he has got poor respiratory effort. As we have discussed in the diagnosis part, that there's a lot of work of breathing. There's a lot of retractions. The SpO2 is not maintaining. He's not able to. So that is the time, because of the poor respiratory efforts. So that is the time that we take a call that this patient needs intubation and he needs invasive ventilation. So far, so good. Now, once we have taken a call that now we have to do mechanical ventilation. So what are our aims? Basically, we want to improve oxygenation, and if there is a accumulation of carbon dioxide, we want to remove that. So my aims and goals are very, very simple, that I have to improve oxygenation and I have to clear the carbon dioxide, which is called as ventilation. Okay. So you have been told by Manisha madam earlier that oxygenation is determined by mean airway pressure and FiO2. FiO2, everybody knows that how much oxygen we give with the prongs, nasal mask, non-breathing mask, 40, 50, 60, and 80%. And then the mean airway pressure, which will be determined by your PIP, PEEP, TI. So there will be various factors which we can titrate to improve oxygenation. We'll come to that. And ventilation is determined by your minute ventilation, which is a product of rate and tidal volume. So we have to choose a rate accordingly. If we have to wash out carbon dioxide, we may have to increase the respiratory rate, or we may have to alter with the tidal volume, apart from the physiological tidal volume, which we all know that which is 6 to 8 ml per kg. So these are the parameters which we will be playing while titrating the patient to achieve the optimum oxygenation and ventilation. Let me tell you that we don't aim for near total, that bilkul I have to reach this much target. So that is ideal target. So that we should not try to, we should try to reach optimum, because mechanical ventilation is not the safe modality of ventilation. It has got its own risks, pitfalls. So we have to use the technology or the technique for the benefit of the patient. Now, what are the modes of ventilation? The modes of ventilation may be controlled mode ventilation, CMV, or it may be assist control, that is ACV. They all are mentioned in your ventilator. When you open up the ventilation, these modes will be there, that you have to choose one of these modes. Then there may be synchronized, intermittent, mandatory ventilation. Then along with synchronized, we may add up pressure support ventilation, PSV, another good development. And primarily, if we see ventilation, there are two types. Either we use the pressure control or we use the volume control. Of late, many studies have come which have found that even volume controlled ventilation is good enough as far as pediatric ventilation is concerned. So it is somewhat a personal choice. You can choose whichever mode you are comfortable with knowing the positives and negatives of each side. So this is a simplistic view of a ventilator. You already know that in a ventilator, we have got an oxygen source, air source, which comes from the compressor, or you may have a direct air source from the wall mounted in case of a good care center. And then there is something known as blender in the machine, which blends oxygen and air depending upon your FiO2 setting. If you have set the FiO2 up 100%, so that means the machine will be drawing more of oxygen, less of air. So it all depends how much FiO2 we are setting. If we are setting 50%, that definitely it will have an equal component of oxygen and air. So then there are transducers and inspiratory valves in the machine, and then through the circuit the air goes to the lungs, it comes back. Again, there are flow and pressure transducers. All these transducers and valves, they help us in setting the PIP, the PEEP. Okay, all these things are for that purpose. And expiratory PEEP valve is also. So these are the various, as a gross, you can say, these are the things which help, which become a part of a ventilator. Now, let's come to what is controlled mandatory ventilation. As the name suggests, everything is controlled. Whatever we are set, the child will get that much rate, that much pressure, and patient has got no say, no autonomy. So it is all machine driven. Okay, so all parameters are controlled by the ventilator. Patient cannot trigger the ventilator. So in that situation, just imagine yourself that if patient has got some respiratory effort, so the machine will not honor that respiratory effort. It will keep on delivering the rate at which you have set. So either the patient is so sick that he has got his no spontaneous efforts and he is totally paralyzed, sedated, then it's good. Then you can use this mode. Otherwise, if patient is not fully drowsy or sedated and is not paralyzed, then the patient will have some efforts. So in that situation, that will become a disadvantage. So you can use this mode only in the apneic patients. There will be a lot of asynchronization if the patient has got spontaneous breathing. Otherwise around, you have to use a heavy sedation and muscle paralysis to keep the patient totally sedated and paralyzed so that machine can deliver whatever you have set. So that is the story about the controlled mandatory ventilation. May be used in some of the cases where you require heavy sedation and muscle paralysis, but those things also have got their own merits and demerits. So let's move ahead. Assisted control. So now there's something better than the CMV. That means here the patient can trigger himself. Though we have given certain mandatory breaths, but in between those breaths, in case the patient wants to trigger, so patient has got some autonomy. So these modes come under the heading of patient triggered ventilation, PTV. That is what we call it. So here the patient has got that trigger the ventilator, and the other parameters, now the ventilator is trying to honor the patient's breath also. Let's understand in this fashion. But if the ventilator keep on honoring each of the requests, then there is a problem of ventilation as each effort is assisted. So, and again, there is a chance of asynchrony between various, because some of the breaths will be triggered by the patient. So ventilator is helping those, and is also giving, the machine is also delivering the breaths which you have set in. You may have set in 20, 30, depending on the age and condition of the patient, and patient is also having 20. So it may amount to hyperventilation, which may result in CO2 washout, which may not be desired totally. So it is something somewhat better than the CMV, but not fully. Here also you may require some amount of sedation. You will require some amount of sedation to avoid the pain and pain of the intubation or the tube inside. Okay. So now another mode has come, which all of you are must be familiar with. That is, we use it very frequently. That is SIMV. Even SIMV, when you use with the patient who is totally knocked off, you have given so much of muscle relaxant and sedation. So even synchronized independent mandatory ventilation will become a controlled mandatory ventilation. Understand? But the beauty is that in synchronized independent mandatory ventilation, you fix certain amounts of breaths. Yes, I want to give 20 breaths to the machine. And in between those windows of mandatory ventilator breaths, in between, like here, patient is able to spontaneously breathe without ventilator interfering in that. So patient is free to breathe during expiratory pause. This is a ventilator breath, there is a sister breath, then there is a window here in which machine is not bothering the patient, so patient can breathe in between. So that is the advantage of this mode. That means the patient can breathe spontaneously between the breaths, and ventilatory support is tailored to the patient's demand. You know that patient has got this much, some effort is there. We'll come to that how that effort has to be picked up by means of triggering. Then this helps us in a weaning sort of a thing by gradual reduction of. So if you keep on decreasing the machine breaths, then allow the patient to breathe. So it's a sort of a weaning mode, you can say. It will require reduced need for sedation, and we are trying to preserve the spontaneous respiration, which will prevent the respiratory muscle atrophy. So there are certain good things about this mode. But maybe some amount of expiratory asynchrony may creep in. So it's a good mode, but a little bit chance of expiratory asynchrony may be there because of the spontaneous breaths. Now, to sort out that issue in between these breaths, these spontaneous breaths, if we try to support these breaths also, the patient is triggering, and we try to help that patient, we give some pressure support so that he is able to generate little more pressure and more volume and more improves the ventilation. So that is what is called pressure support ventilation. That means we provide the support to the spontaneous breaths to eliminate the additional workup. So we are trying to help the child that in those spontaneous breaths, we help the child, yes, give little bit pressure so that he is able to generate adequate tidal volume. So basically, it will relieve the work of breathing in the spontaneous breaths of SIMB. This is where the PSV has got a role. Okay, so maybe used as an independent mode also. If the patient is breathing, but his work of breathing is there, so we can just use alone as an independent mode as a pressure support, that we are just supporting those breaths so that patient does not tired of or fatigued nahi hota patient. And here the patient can initiate a breathe. So there's a good thing. So it's a patient has been given an autonomy. Patient's effort must exceed the trigger sensitivity. Now here comes the word trigger. You must be recollecting that in the initial talks, first talk, the madam must have told about the triggering that pressure, limiting, and triggering. Okay, controlled when she must have told about the various phases of ventilation. So in a trigger, one is your machine triggering. That is a time trigger. Because you have set the TI that this much breath dena hai, फिर उसको छोड़ना है, so that expiration के लिए you are giving time. That is a time. That is a machine fixed है. उसमें आप कुछ नहीं कर सकते. That you have already set. The other trigger will be either flow or pressure. That means you want that patient generates some amount of flow or some amount of pressure, and you set that trigger sensitivity. I want this much pressure if the patient generates, then the ventilator should detect that pressure and then deliver that breath, assist that patient in that breath. So if you set very, very low sensitivity, very, you have set a little, maybe -1 centimeter pressure aapne rakh diya hai. So the patient will have some effort, ventilator will pick up. If you keep the sensitivity of -3, -4, that means you are keeping the higher sensitivity. In that situation, the patient has to have that much effort. Only then the machine will judge that patient has initiated the breath. So it all depends. So the trigger is available on most of the ventilators. One just has to go there, and you can change the mode also, that it can be pressure or it can be flow. At times it can be only pressure also. So depending upon -1, -2, -3, -4, -5, there's a range of 1 to 5 only. So depending upon that, if you set कि -1 करता है तो वो काफी ट्रिगर करता रहेगा. अगर आपने -5 सेंटीमीटर रखा है तो वो कम ट्रिगर करेगा. That means the patient, the child has to generate that much pressure to breathe inside, so that the ventilator will be able to judge or pick up that trigger. Okay, so that is how the trigger sensitivity works. Then the ventilator, the machine gives the flow to attain the target pressure, whatever pressure you have set. For example, you have set the 14, so patient is able to generate 5, then you have set 14, so he will deliver another 9 centimeters, so that he is able to reach the level of 14. Okay, depending upon 12, 14, whatever pressure you set in. So it's a good mode. That means it is synchronizing with the patient's effort. Inspiratory flow continue to maintain the target PS level as long as the patient's spontaneous effort continues. That's a good thing. That it negotiates. The machine negotiates with the patient's effort and helps in more synchronization. Okay, so that is a good thing about the pressure support ventilation, and it can be used in combination with SMV. Hope I am clear. Now let's come to pressure support and the volume support ventilation. This is how the graphs or the pulmonary graphics or the loops will look like. If you this is how, once the patient machine triggers, the graph will be like this, and the flow will be a sharp rise in the flow, and then it comes back. Okay, inspiration and expiration. So pressure support ventilation में all breaths are initiated by the patient. So patient has got that much autonomy. Once initiated, the ventilator supports the inspiration to a prefixed pressure level. आपने 15 रखा है तो 15 तक support करेगा उसको. Then pressure support only as long as the patient is in the inspiration. So the problem of insynchronization is also avoided. So the patient judges that the baby is in the inspiratory phase. So it will give that much pressure in that period only. That's the good thing about this. But only thing is, as I told you earlier, we have to set the trigger pressure or volume depending on the patient's condition. We have to set a pressure support level. Maybe some of the ventilators may have to set up the pressure support slow. And other things you have to set that there is a PEEP, FiO2 and alarm, as has been mentioned in the previous talk. So there may be expiratory triggers also in some of the ventilators, but if we have the inspiratory trigger, so this will expiratory trigger will add another beauty, that even asynchronization during expiration will not be there. So these are the few things which add up once you radio button the pressure support. So these parameters will come. So you have to choose and select those parameters. Okay. So advantage is that it preserves patient's effort. Patient has got a control on all phases of respiratory cycle. It relieves the work of breathing in proportion to the level of support, whichever you have set. But definitely, the patient has to breathe spontaneously. If the patient is not breathing spontaneously, so then you can't use this support ventilation. Okay, and there will be variable tidal volume and minute ventilation with varying lung mechanics and patient's effort. So as in an acute stage, we may not be able to achieve the minute ventilation and the tidal volume, but as a condition will improve over the next 48 to 72 hours, the disease process starts improving, the pathogenesis starts settling in, so we will be able to achieve the optimum tidal volume and minute ventilation. Okay, so let's debate about the PCV and the PCV, that volume controlled or the pressure controlled modes. Both have got their pluses and minuses, because volume trauma, barotrauma, these terms we all are very familiar with. They can cause various types of problems, and volume control will assure you of the tidal volume, that this much tidal volume is there, and it is assured that this much will be delivered at all costs at whatever pressure it may be. The pressure may be, because if there is a lot of resistance, compliance is poor, then the same amount of volume will generate too much pressure. As the situation improves, the compliance improves, the pressure generated by the same volume will be less. Similarly, in a pressure controlled ventilation, we have set the pressure, that pressure maybe in the initial stage of the condition may not be able to generate that much tidal volume. But as the condition improves, so initially we may have to have a higher pressure settings so that we are able to achieve near normal tidal volume, but at the risk of barotrauma. So we have to have a, it's a double sword, both of them. But once we know that patient requires our help, so we have to choose, and whichever mode you are more comfortable with. Most of the studies of the volume control also says that is a good mode. So this is how the pressure control ventilation will be, that the ventilator delivers an inspiration at a set pressure level for a fixed time. You have set the time Ti, and this much is the pressure, so it will deliver that much pressure, and the tidal volume will be variable. That is determined by the lung mechanics, as I explained to you earlier. Similarly, in the advantages will be that you know that how much is the non-barotraumatic levels of pressure. So you try to limitation of the airway pressure to non-barotraumatic levels. Then we should not go beyond those levels, because we know that we give too much of a pressure, the lung can burst, leading to pneumothorax. Another advantage of pressure control is that it helps us in keeping an increased MAP by recruitment of the alveoli which are not taking part. So once there is an increased PEEP, that helps us in the recruitment of the alveoli. But we may not be able to achieve fixed tidal volume. It may be variable. And if we set high mean airway pressure to achieve the alveolar recruitment, then we may lead up in a hemodynamic dysfunction. That means too much of a pressure, which will impair the venous return, and thereby it will decrease the cardiac output. So one has to have a balance of these things. That is what the beauty is art of ventilation, and more of a art. And once you know the science, then it is the art. Okay. Now in a volume controlled ventilation, the ventilator delivers pressure to achieve the set tidal volume. However, the pressure will vary with the breath. So this is a controlled tidal volume will remain unchanged. So the ventilator machine will give the desired tidal volume. Whatever you have set, it will keep on giving. But there may be pressure changes may be different depending upon the lung mechanics. So that is all about the volume control and the pressure control. Definitely advantages have got, both have got their own advantages and disadvantages. In this, probably there's a reduced work of breathing. We are giving an adequate tidal volume, and it allows the patient to increase the minute ventilation, because you can't decrease below the set minimum tidal volume is assured. Understand? So that's the advantage. But naturally, it has got some adverse effects on the hemodynamics of or inappropriate hyperventilation. Airway pressure will change. As in the pressure, it is the volume, tidal volume, which will change. However, in the volume control, the airway pressures vary with the changes in the lung compliance. And then, since we are giving a fixed flows, the high flow demands for the patient may not be met. So the patient gets ventilator dependent. So that is the little minus or demerits of volume control ventilation. But in a desperate situation, we have to use either of these. So this is how the curves will be. Volume cycle, the airway pressure will rise gradually, whereas in the pressure control, it will be like a square waveform. The alveolar pressure will be a gentler rise, and in a pressure cycle, it will again be like a parabola sort of a thing. The flow will be a square form in the volume control, whereas in the pressure control, the flow will be a sudden rise, and then the patient goes into expiration phase after the TI period is over. So these are how the graphics will look like. So the message is that synchronized and patient-triggered ventilation, that the PTV, they are preferred. So always use those. Sick children, definitely, they may require some amount of sedation. You can use assist control. Otherwise, mild to moderate illness, you can have SIMV. And the best thing is that choose the mode in which you are confident. Do monitor the delivered parameters, because these ventilators, these machines give many parameters: compliance, dynamic compliance, resistance, expiratory tidal volume, inspiratory tidal volume. So as you go inside the machine, on the display unit, you will assess that how much you are able to achieve the target parameters. And alarms already, they have already said that you have been told about that please, similarly in the multi-monitors, as in the multi-monitors, similarly in the ventilator also there are various alarms, audio-visual. So one has to look into that, why the machine is giving alarm, red color alarm, it is keep on blinking. So please to see to that. It may be saying there's no oxygen, there's a pressure failure, there is something. So please listen to that message which comes along with the blinking, that what is the cause. There may be too much leak, there may be oxygen failure, there may be disconnection. So all those things, the machine tells you that please check. There may be some, so you have put the water in the humidification and you have forgot to cap that humidifier. So the machine will immediately picks up that there is a leak. So one has to go into those alarms. Okay. So there's a lot of thing to study. Anybody who is interested, basically it's an art, and one must develop that aptitude based on the scientific knowledge. I hope that you are able to understand the different types of mode, and it will be easier to choose a mode, though there is not much of a choice. But nowadays the new ventilators are coming, which has got the hybrid modes. That means the high-end mode, high-end ventilators, for example, they will guarantee volume guarantee, pressure regulated, volume guarantee. So many things are on the development already there. There are so many ventilators are there which gives you another modes. That means they are trying to optimize pressure and volume, basically pressure and volume, so that you achieve the best of the mix. Okay, then setting the parameters, there will be a next session on that after lunch, once you replenish your glucose stores. And please do analyze the displayed parameters, which will definitely help you. Our aim is that we should try to avoid asynchrony, see to it that the patient and ventilator, they are in sync with each other. That's the best ventilation target to be achieved. Lot of thanks to many contributors for this module. Special to Office of DGME, Professor Shelley Madam, Chandrakanta Madam, who has been there weeks after weeks for last 3 months, I hope so. And in the hope that we all are well prepared for the next wave, if it is there. Okay, thank you so much. If there are any questions, it will be my pleasure.
Thank you very much, sir. Thank you. So there is only one question for you. There is a question: when the patient is on muscle relaxant in SIMV mode, how spontaneous breathing will happen in the expiratory phase?
That I told you, that if you use muscle relaxant in a SIMV mode, it becomes like a controlled mandatory ventilation. Naturally, you will not have that option. आपके पास कोई option नहीं है, because आपने उसको relax कर दिया है, तो कहाँ से breathe करेगा? So then you have to have the mandatory breaths only. So in fact I mentioned that if you give sedation and muscle relaxant, and if you use SIMV mode in that also, so that SIMV mode will act like a controlled mandatory ventilation. So it will become a CMV. So as you start decreasing those relaxants and sedation, patient starts taking the breaths. So that is how the spontaneous breath will happen in that respiratory phase, in the respiratory cycle. So definitely, then the patient will not breathe. Then there is no asynchrony as such. So it is all machine controlled. It is all machine controlled, Dr. Sanjeev.
Thank you, sir. So I think all the participants must be feeling hungry by now. So we take a short break of 20 minutes, and at 2:20 we will again restart our session.
Hopefully all is well, ma'am, at KGMU.
All is well, sir. So we are close to finish our job. So it's training
Okay.
is almost complete.
How long September will be there?
This may be the last one probably.
Okay,
So
okay,
we
okay.
have to confirm
Good.
from.
Because today only we received a letter that for the nursing personnel, the call for so many people should attend, something like that. There was a letter from the
So this
DGME.
must be for Friday, Saturday. Nursing will also
Okay.
probably
Because,
continue this week.
I don't know COVID situation at your place, but हमारे पास तो we don't have. In fact, dengue cases
We
and
don't have, sir, right now.
encephalitis cases are coming now.
Yeah. Yes, sir. Okay.
Thank you, madam.
Sir.
Thank you.
Thank you, sir.
Hello? Hello? Just 20 minutes. Good afternoon, everyone. If the participants are here, should I start with my lecture?
Dr. Kavita, maybe you can, another 2 minutes, you can wait because
Okay, sir.
these
Okay,
people, because last time it was about 190, now there's only 107.
107, right, sir?
Maybe by the time Dr. Chandrakanta will also pitch in.
Actually, sir, ma'am messaged me that she'll be in a meeting.
Okay, so you start off. Okay.
Okay, sir. Thank you, sir.
No
Good
problem.
afternoon.
No
Good
problem.
afternoon. Good afternoon, sir. Good afternoon, everyone, all the participants. This is the lecture in the post-lunch session, and this lecture is about endotracheal intubation in children. So in this lecture, we'll be talking about understanding the key anatomical differences between pediatric and adult airways. And we'll be talking about comprehension of the equipments and preparation required for endotracheal intubation in children and procedural step of performing endotracheal intubation. So we'll be covering indications, contraindications, anatomy, preparation, procedural steps, aftercare, potential complications, and common pitfalls. For indication of endotracheal intubation, if there is a failure of oxygenation or ventilation, like partial pressure, arterial partial pressure of oxygen is less than 60 millimeters of mercury on 60% FiO2, or if the arterial partial pressure of carbon dioxide is more than 50 millimeters of mercury, or if there is any inability to maintain or protect the airway, or if there is any severe systemic condition like hypotensive shock, or patient requires cardiopulmonary resuscitation, or patient requires anesthesia or procedures requiring sedation, or if there is any neuromuscular disorder. There are no absolute contraindications for endotracheal intubation, but there are certain relative contraindications. These are anticipated difficult airway, the patient is difficult to intubate, or the patient requires alternative airway, or we are waiting for the expert team. Now, there are some basic differences in the anatomy of adult airway and in the pediatric airway. Starting from the tongue of the adult is smaller compared to the pediatric patient. In case of pediatric patient, the tongue is relatively large. And in adult patient, the epiglottis is shorter. In case of pediatric patient, epiglottis is floppier and it is U-shaped. If we talk about the narrowest part of the airway, then in case of adults, the vocal cord is the narrowest part, whereas in case of pediatric patient, the cricoid ring is the narrowest part. And if we talk about the overall placement of the airway, in case of pediatric patients, the airway is naturally more anteriorly placed compared to the adult airway. So this makes our job a bit difficult. So what do we need for a successful intubation? The first thing we require is airway alignment. So we can see this slide. There is a relatively large head size in infants, and there is a natural neck flexion because of large head size. And this neck flexion leads to compression of soft tissues into the neck area. And the tongue is relatively large. So the tongue keeps falling back, which leads to the airway obstruction. So how do we align the airway and how do we achieve the snipping position, which is the ideal position for endotracheal intubation? So there are certain endpoints, like if we see the point number 1, the glabella and chin plane should be in straight line, and this should be parallel to the ground. And if we talk about the point number 2, so neck, there should be a wide and neck should be wide and open. There should not be any compression. And the external auditory meatus of the patient should correspond to the suprasternal notch of the patient. This should make a straight line, and this line should be parallel to the ground on which the patient is lying. So these are the endpoints we should try to achieve and to achieve the sniffing position. So this is the slide which is showing where we are lacking, like the glabella in chin plane, it is not parallel to the surface, and these are not the same goes with the external auditory meatus of the patient and the sternal notch, which is not parallel to the surface. So how do we achieve it? To achieve the sniffing position or ear to sternal notch position, we can try placing a shoulder roll if the patient is infant. And after placing the shoulder roll, we should check the ear of the patient and a line which is going from the anterior part of the shoulder. This line should be straight line, and again this line should be parallel to the ground. In case of small child, we may not need to place anything, and we should check this line. It should be parallel to the ground or the surface. Or in case of older children and adult, we can achieve this position by placing a support behind the neck of the patient. So after placement, we need to know what we are looking for. So there are key anatomical landmarks we should have a clear idea about. So these are the landmarks. So this is the airway of the patient after laryngoscopy. This is the view that we achieve. This is the epiglottis. This is varicula. These are the vocal cords. These are the arytenoid cartilage. These are the epiglottic fold, and this is the glottic opening, which is the target. So this glottic opening is lined by the vocal cords, which are the glistening white structures, which we are able to see after doing the laryngoscopy. So this is again showing the anatomical landmarks. The one important thing which is shown in this slide is the esophageal opening. So we should know how the airway opening is different from the esophageal opening. First of all, the shape, and these vocal cords, which are the white structure, which is lining this opening. So there are different shapes of the epiglottis according to the age of the patient. If it is a newborn, it has the inverted U shape. If it is a child, it is triangular in shape. And if it is an adult patient, it is semicircular in shape. So after aligning the airway and identifying the target, there are certain preparation which we need to do. And we can remember this preparation by soap mnemonic. So what we need is the suction apparatus, which can be wall mounted or which can be standalone. Suction pressure should be 80 to 100 millimeters of mercury. Suction tube should be ready, and we should have suction catheters in the sizes of 8 to 14. Then we need oxygen, which can be provided by non-rebreather mask or by the nasal cannula or by ambu bag with the reservoir. And we need oxygen tubing. For the airway, we need appropriate size of endotracheal tubes. We need oral and nasal airways. And then we need laryngeal mask airway just in case we require. And the other thing which is very important is the personal protective equipments which should be kept ready. Then we need medications like pre-medications, paralytics or resuscitative medications like epinephrine, atropine, fluids, etc. And we need equipments like laryngoscopes, appropriate size blades for the laryngoscope, and appropriate size mask, ambu bag, stillet, working IV lines, syringes, tapes, towel pads for airway alignment, stethoscope or monitor, end-tidal carbon dioxide or the calorimetric capnograph, and ventilator. So this is the checklist of the equipment we need before attempting for laryngoscopy and intubation. So if we talk about the laryngoscope, we use two type of laryngoscope. One is the Miller blade and one is, these are the blade of the laryngoscope. One is the Miller blade and other one is the Macintosh blade. Miller blade is straighter, thinner, and it can be used in infant and children. When we are using the Miller blade, we directly lift the epiglottis and it provides better control of tongue. And if we are using a Macintosh blade, the Macintosh blade, as you can see, it is curved and it is wider, and it can be used in older children and adults. And when we are using the Macintosh blade, we place the Macintosh blade into a tip of the Macintosh blade into the vallecula and we lift the laryngoscope. And we see this is the Macintosh blade which is curved. So it curves around the tongue of the patient and keeps the tongue away from the area of visualization. There are different sizes, like in three terms, the size is 00 to 0. In case of term, it is 0 to 1. For infant and toddler, we can use Miller size 1. For preschool children, we can use Macintosh size 2. And for school children, we use Macintosh size 2 to 3. So now we need appropriate size endotracheal tube. So how we can calculate the size? So if it is an uncuffed tube, we can calculate by the formula Ag near by 4 plus 4. And if it is a cuffed tube, then we can calculate by Ag near by 4 plus 3. So after calculating the definite size that we need, we should always keep a size higher and keep a size lower below the appropriate size. Then till what depth we should insert the endotracheal tube? For this also we can remember by Ag near by 2 plus 12, or we can just roughly multiply the internal diameter which is mentioned on the package of the tube or on the tube by 3, and that's how we can calculate the depth of insertion. Cuff pressure should always be less than 20 centimeters of water. So these are different sizes of endotracheal tube, which we might need in case of pediatric patient according to the age. So the size of the endotracheal tube is labeled according to the internal diameter. So these are the various internal diameter. And if we are using a cuff tube or we are using an uncuffed tube, there is a corresponding external diameter. So this is mentioned here. the internal diameter and the corresponding external diameter according to the cuff or uncurved. Then other important thing that we might need while doing the intubation is the glidoscope stellate or elastic bougie or other type of stellate. These stellates really aid into our intubation and they really help. We can preform the shape of the tube just in case if we are facing any difficulty or if we are not able to identify the ear properly or only the tip of the epiglottis is visible. So these are very helpful in case of difficult visualization and difficult intubation. The other adjunct equipment that are required is the ambu bag. So the size of the ambu bag is again according to the pediatric age of the pediatric patient. If it is neonate, we need 200 to 300 ml. In case of infant and young children, we need 450 to 500 ml. If it is an adolescent or an older children, then we need 1000 ml to 1500 ml. Then we need appropriate size mask and we need to learn how to hold the mask. So to memorize, we don't need to memorize the size of the mask. We can just pick a mask and place the mask slightly on the airway of the patient, just like it is shown in the figure. Just like it is shown in the figure. The triangular portion of the mask should be on the bridge of the nose and the round portion of the mask should be on chin. The mask should not be small enough as it is not covering the nose and airway properly, or the mask should not be large as it is covering the eye of the patient. So that's how we can get a idea about the appropriate size of the mask. And once we have chosen the mask, we should know how we properly hold the mask. So we can use E and C technique. So this is the C or this is the C and this is the E. By this C, we are with thumb and index finger, we are pressing the mask on the nose and mouth of the patient. And by this E, these fingers are placed on the bony prominences of the chin. And by this E, we are trying to lift the airway of the patient in the outward and in the upward direction. And this is a maneuver which is called jaw thrust. So we are basically trying to give the jaw thrust to the patient, which will open the airway, which will align the airway. And with this C, we are holding the mask and pressing on the nose and mouth of the patient. So there is another technique, which is the two-hand technique. So in this two-hand technique, we use both our hands and with the thumb, we are pressing the mask on the nose and mouth of the patient. And with the finger, we are again trying to move the mandible in the anterior and in the upward direction. Again, this is the technique with which we are trying to give the jaw thrust to the patient so that we can align the airway. Then we need other adjunct equipment, which is the suction apparatus. So for the suction catheter, for the defined size of the endotracheal tube, the suction catheter size is also defined. So we should have a suction catheter according to the size of the endotracheal tube. And again, the suction pressure should be 80 to 120 millimeters of mercury. We should not go for a pressure higher than this because mucosa of pediatric patient is very gentle, very friable. It may lead to bleeding if we are going for high pressure. So try to keep the suction pressure 120 below 120. Then we need oropharyngeal airway. Oropharyngeal airway helps in keep opening the patient and it helps in preventing the patient from biting the tube also. So for oropharyngeal airway, we use the Goodell airway, which is available in the size of 00 to 4. The length of the airway is 4 to 20 centimeter of the length. And for the appropriate size of the Goodell airway, again, we can keep a airway on the midpoint of the incisor of the patient, and the angle should corresponds to the angle of the proximal distal part of the oropharyngeal airway. Distal part of the oropharyngeal airway should corresponds to the angle of the mandible with the curvature facing in the upward direction. So this is how we can calculate the size of the oropharyngeal airway. Oropharyngeal airway for easy memory are also color coded. So we can remember it by the color or by the size, or we can calculate by the size like this. Then other adjoint equipment that we require is the endotracheal tube. Once we have achieved our laryngoscopy and intubation, we need to secure the endotracheal tube or the laryngeal mask airway at its plates. So for that we need tapes. The other thing we require is the pulse oximetry for monitoring, capnography for monitoring, and we need the personal protective equipments. Pre-medication that are required are the tranquilizers, which can be benzodiazepines or promethazines, benzodiazepines like midazolam, or opioids like fentanyl and morphine, non-opioid analgesics like acetaminophen, dissociative agents like ketamine, or anticholinergic agents like glycopyrrolate or atropine, or antacids or H2 blockers like ranitidine or metoclopramide. We can use midazolam, we can use ketamine. The route of administration of the drug can be intravenous or intramuscular. The dose differ according to the route of administration. Same for the ketamine, we can give intravenously also, we can give intramuscularly also. The drug for resuscitation, because we might face certain complications after the procedure or during the procedure. So we should have a epinephrine loaded syringe ready in the dilution of 1:10,000. And the dose is 0.01 mg per kg IV. We should have tropin ready with us in the dose, and it can be given in the dose of 0.02 mg per kg in case we are facing the bradycardia. We need IV fluids for the resuscitation like normal saline, or we need calcium gluconate and the steroid like hydrocortisone. Now we perform rapid sequence intubation. There can be there are different scenarios where we need rapid sequence intubation, and COVID is one of them. So we all know about the rapid sequence intubation. What is most important while doing the rapid sequence intubation is the use of neuromuscular agent. So before using the neuromuscular agent, either you are using the neuromuscular agent or you are not using. But if you are using the neuromuscular agent, then always check ventilate the patient before giving any neuromuscular paralytic drug to the patient, because we don't want to land up into the situation of not ventilating and not intubating. So we should always check ventilate the patient if we are using a neuromuscular agent. Drug for rapid sequence intubation are for induction agent. It can be etomidate, propofol, ketamine, fentanyl. So the indication of these drugs is dependent on the availability of these drugs and the condition of the patient. For the depolarizing paralytic agent, we can use succinylcholine. For non-depolarizing paralytic agents, we use rocuronium and vecuronium. For pre-oxygenation, we use 100% oxygen for 3 to 5 minutes. Why? Because pre-oxygenation will increase the safe apnea time of the patient. So to pre-oxygenate, if the patient is spontaneously breathing, we can use non-rebreather mask or the nasal cannula. Or if the patient is in apnea, or patient is gasping, or patient is not breathing properly, then we use bag and mask ventilation for these situations. So step one before attempting for laryngoscopy and intubation is proper position. If we are able to achieve the proper position, then the seemingly difficult airway becomes easy for us. So first of all, focus should be on the proper position. Keep the patient on the horizontal surface. Give a gentle neck extension. And in case of step two, we need to hold the laryngoscope. Try to hold the laryngoscope into the non-dominant hand, or with the dominant hand, we need to do the airway manipulations. So this is how we hold the laryngoscope. We hold the laryngoscope near the blade, or we hold the laryngoscope by the handle. It again depends whether we are dealing with the pediatric patient or we are dealing with the adult patient or adolescent patient. So for holding of the laryngoscope, two techniques have been defined that we have discussed. One is holding by the handle, which is the classic technique, and one is holding by near the tip of the blade of the laryngoscope. So this uh, technique provides better control, because in case of pediatric patients, we need to do gentle airway manipulations. So this technique provides a better control of those manipulations when we are dealing with the pediatric patients. Step 3 is opening the mouth. For opening the mouth, we can use the scissoring technique. With the thumb, we are pressing the lower lip of the patient, and with the finger, we are trying to deviate the tongue and opening the mouth of the patient. Then introducing the laryngoscope. We should try to introduce the laryngoscope from an angle of the mouth of the patient. We should not introduce the laryngoscope middle of the mouth. In step 4, again, this is shown the insertion of the blade. We have already mentioned we should always insert along the angle of the mouth of the patient, and then while inserting, we should try going in the opposite direction of the angle, moving the tongue away from our area of visualization. Then this is the full insertion of the blade inside the mouth of the patient. This is again showing the incorrect blade insertion. And after we have done the laryngoscopy, the landmark, we have a picture in our mind. We should identify those landmarks. And this is the epiglottis that we try to identify. And after identifying the epiglottis, as for the cricoid pressure, when we give the cricoid pressure, then there are certain indications to give the cricoid pressure, like a full stomach patient, trauma patient. So deciding to give the cricoid pressure is always depends upon us. But now it is said that cricoid pressure distorts the airway, and as such, it is very difficult for us in case of pediatric patient to identify the airway. So cricoid pressure will again makes our job difficult. So again, it depends upon the person who is doing the laryngoscopy and intubation, whether you want to use the cricoid pressure or whether you don't want to use. So after we have identified the epiglottis, we need to engage the blade into the vallecula. Once we have engaged the tip of the laryngoscope into the vallecula, we lift the laryngoscope, and then we expose the glottic opening. So this is the glottic opening. Then other step, the last step is basically insertion of the endotracheal tube. And once we have inserted the endotracheal tube inside the glottic opening, we have achieved the intubation of the patient. So once we have achieved the intubation, what we need to do is checking the correct placement of the endotracheal tube. If we should auscultate the bilateral chest, and if bilateral chest audible sounds are there, audible breath sounds are there, then you are correct. Or if we are seeing the patient with our eyes, then there should be a chest rise with each ventilation. And again, auscultation over abdomen, there should not be anything audible. In case of monitor, SpO2 should be more than 90%. In case of capnography, there should be a proper waveform, or there should be a color change. Or if we are relying on chest X-ray, then the tip of the tube should be 3 centimeter above the carina. So this is the waveform that we were talking about. This is the capnography, and this is the waveform that we achieve once we are at the correct place. And this is the chest X-ray, which is showing the tip of the endotracheal tube above the level of the carina. So this is how it should be visible. We might face difficult laryngoscopy, difficult intubation. In case of difficult intubation, if we are not able to achieve endotracheal intubation by the ET tube, then we can use laryngeal mask airway. So before using the laryngeal mask airway, always deflate the cuff, lubricate the dorsal surface of the tube, then hold the LMA into the pen holding fashion. and then LMA is inserted along the hard palate and roof of the mouth. So keep inserting and keep advancing. Once we know that we are at the correct place, inflate the cuff of the patient, cuff of the laryngeal mask airway. There will be slight outward movement of the laryngeal mask airway. Then we need to secure our endotracheal tube or the laryngeal mask airway. For that, we need tapes. So these are the tapes that we use for securing. And there are different methods of securing your tube. We can use the technique of maxilla to maxilla, or we can use the technique of maxilla to mandible. So this is how we secure the tube. We paste the tape, and then we rotate it around the endotracheal tube, and then we paste it on the upper or the lower lip of the patient. So this is again showing securing of the endotracheal tube. The potential complications that can be faced during the procedure or after the procedure can be hypoxemia or bradycardia. Patient may land up into hypertension or hypotension. There can be laryngospasm, bronchospasm, or we can cause trauma to the mouth or trauma to the larynx or vocal cords. Or we can do esophageal intubation, or we can lead to perforation. There can be tracheal perforation, or there can be emesis, which can lead to aspiration and cardiac arrest. So if we are facing acute deterioration post-intubation, then we should rule out displacement or misplacement of tube, or obstruction, which can be because of the secretions or bleeding, or pneumothorax, or we can face equipment failure like ventilator failure. So common pitfalls that occur while doing the procedures can be because of blocking movement of the laryngoscope, or there is inability to visualize the glottic opening, like blade is inserted too deep, or there is an improper positioning, or we have done the right mainstrip endotracheal insertion and only one part of the lung is being ventilated, or we have taken the multiple attempts. So we should try to keep our attempts less than 3 within 20 to 30 seconds, or we should always have a equipment checklist before attempting for procedure, be it laryngoscopy intubation or be it any other procedures. So how the scenario is different in COVID-19 patient? So first of all is the personal protective equipments, which should be our priority. Then experienced person should perform the procedure. We should always avoid awake intubation so that aerosol generations can be minimized. Inflate the endotracheal tube once it is inserted, but before bag and mask ventilation, and use of inline suction catheter, not the open circuit catheters. We should try using inline suction catheters. Now, there are innovations which really help us in protection also, and help us in identifying epiglottis and our airway, like the video laryngoscope. This provides distance from the mouth of the patient, first thing. And the other thing, it makes our visualization very easy. So it decreases the complications that we face. So our take home message for this lecture of endotracheal intubation will be: pediatric intubation is an important skill and is in management of critically ill children. Knowledge of relevant anatomy is very important, and appropriate equipment should be kept ready at all times in pediatric ICU and crash cart. Medications are an important component during intubation, so we should have idea about types of medication, dose of medication. Stepwise insertion of technique should be performed for optimal success. It is very, very important in pediatric patient, because as we have already discussed, we sometimes tend to miss the epiglottis because we go too deep inside. So stepwise and gentle, no hasty movements while doing the procedure in pediatric patients. Post-intubation care is an essential part of intubation process, and the complication should be anticipated early and treated early. So this was my presentation. Thank you very much. Any questions that you would like to ask? Sir, are you there?
Yes, hello, I'm there.
Okay. Okay. Yashwant sir? Hello?
Yeah, we are.
Okay, now
Yes, hello.
I would like to invite Dr. Yashwant Rao, GSVM Kanpur. Sir, please welcome and please take the next lecture.
Dr. Kavita, there is a correction. Dr. Yashwant Rao is not available. So I'm
Okay.
Dr. Siddharth Kumar from KGMU who
Okay,
will be
sir.
taking this lecture.
Okay, sir. Okay, sir. Okay, sir. Thank you, sir. Now I hand over the rest of the part of presentation to you, sir.
So kindly stop sharing so that I
Okay,
can
sir.
start.
Okay, sir. Thank you, sir.
Thank you so much. Thank you so much, Dr. Kavita. So is my screen showing? Hello?
It's visible.
Yes, yes, it's showing.
Okay,
Visible.
and thank you. So after we have chosen the patient, the patient has to be given put onto the oxygen therapy, and we have been trying different oxygen therapy modes of oxygen therapies and escalating the oxygen FiO2 support by FiO2 pressure, and sometimes even with NIV our say flow changes, we can do that in the NIV. So perhaps all of that has not worked, and we have not infinite time to try on to non-invasive modes of ventilation. So this is the time we should hop on to quickly start mechanical ventilation. So let's start. Let's take a case to generate a scenario. There is a 10-year-old male female. The patient is obese. He's having fever for 5 days and pain over the body for the same time. RT-PCR is positive 5 days ago. He developed breathing difficulties and cough for 3 days ago. Started on oxygen at home. Then progressive worsening and admitted to the hospital. Oxygen requirement was increased in the meanwhile, and he was started onto the non-invasive ventilatory support. Increase in oxygen requirement, FiO2 increased to 80%, and what support we have given to the child is 12/8. Continuing, the child after starting NIV is sleepy, appears tired. His heart rate is 135 per minute, which is even for this age more than what it should be. Respiratory rate is 50, which is again more. Chest movements appear shallow. Now, one important thing is if at any point of time, if we are seeing the chest movements are shallow. Shallow means there is something to do with CNS involvement. It may be due to lethargy and CO2 buildup. It may be due to hypoxia. But in case there is respiratory distress or the respiratory excursions are much more, patient may be only having respiratory involvement, respiratory part. But if chest movements are appearing to become shallow, it means somehow, somewhere CNS involvement is there and mechanical ventilation is imminent, and shallow respiration also means that an IV is not going to work. Violate that because one of the important things to keep the child on NIV and continue is his spontaneous respiration. In case the CNS involvement is causing the respiration to shallow, that means now the patient's drive is going haywire and NIV is not going to work. So we have to preempt these things. It's not just mechanical 2 hours of NIV and now, okay, we will put the child onto the mechanical ventilation. Bilateral creps are present. More at basis, increase in oxygen requirement is seen. FiO2 is increased to 80% support and 12-8. We have done this already. Pulse oximetry says 89 to 90% for last 4 hours. And it falls rapidly if the child even removes an IV mask, even to drink water transiently. Has not been able to eat anything substantial for about 1 day. What is the next step? Next step is very easy. We have to put the child onto the ventilator settings. To keep the things easy, we have to choose few things. What mode we will keep the ventilator, the child on ventilator, what respiratory rate, what tidal volume, what inspiratory time, what should be the FiO2 to start, and what should be the P. We may, change the order of these things, but all of these things have to be set. And so, okay, let's go one by one. And I will not be going in very much detail of these, because otherwise the ventilator mode and respiratory and tidal and everything else has been taken care of, and we have discussed all things. Now here is a total combination of all of these things and how to start to go about. And this talk is mainly for the beginners. I think at least 50-60% of you have been already ventilating the children and won't have any difficulty, but this talk is much more for benefit of those who will be starting ventilation. Which mode is the best is the $100 question, but easily answered. The one line answer to this is the mode which you are most comfortable with, which you have seen others working or you have yourself worked in, is the best mode. But there are certain buts we'll talk about. One is volume control or pressure control. So the neonates, because they have very minuscule volume of the lungs, and they cannot afford to tolerate much of volume, much of say pressure changes. Therefore, the independent parameter there, we should keep pressure constant. So most of the times we all do, whenever we are ventilating a neonate, we keep the pressure control mode on. However, in other children, most of us are more comfortable with say volume control. So volume control is also easy. But in volume control, as we are keeping the volume constant, but then the pressure, which will depend upon the compliance of the lung. What is compliance? The change in the volume of the lung per say unit change in the pressure. So for a healthy child who is not having mainly respiratory disease or respiratory, then his compliance will be normal, and we can keep on going on to the volume mode of ventilation. But there are certain conditions in which off and on change in the compliance occurs, like in bronchial asthma. In bronchial asthma, sometimes the compliance is high, sometimes the compliance is low. So there, the pressure will keep on increasing because it can increase to any limits and can cause barotrauma. So there we'll have to think. Then there are other entities. More than many people are, say, very comfortable by keeping pressure control in ARDS. Although this is not the talk, but as we have to choose the mode, in case there is a child, there is not much of lung pathology still certain, we can start by keeping the volume control mode. But the control mode, both are easy. One is assist control or SIMV. We'll talk on later. SIMV is nowadays going a little bit out of favor. There are reasons which are not in the purview of this talk, but SIMV is falling out of favor. Or it should be either assist control or it should be SIMV. If we keep it SIMV, then we should keep it with pressure support. So pressure limited or volume limited, we have talked about this. Volume limited if the child is in more than unit and the lung pathology is not specific. Use the mode which you are more familiar. Both are equally effective provided we are familiar and we do the changes as and when required, which we'll see later on. If volume mode is used, then if we are using volume mode, that means we have fixed the volume as an unchangeable parameter. Volume will be delivered whatever we have done. Therefore, we have to keep an eye on changing pressure breath to breath or minute to minute, because we cannot allow our patient to suffer from barotrauma. In case we have then done pressure mode, then we have to see if the either adequate volume is being delivered, that is atelectotrauma may not occur, and also if the volume, if excessive volume is not being delivered, causing volutrauma. So ventilator settings, perhaps we have changed, we have used our mode, either pressure or say volume. In case we have chosen, then there is respiratory rate. Respiratory rate should be near to the physiological rate if there are no indications to change the rate as per the disease entity. Like these are the age appropriate suggestive rates. In less than 1 year, rate to be kept maybe 25 to 30 per minute. 1 to 5 years, say 20 to 25 per minute. And okay, let me increase the volume bit. Yeah. Then 5 to 12 years rate may be 15 to 20 per minute, and more than 12 years rate, adult type, that is 12 to 15 per minute. But the rate has to be titrated, number one, as to the starting disease entity. In case it is a bronchial asthma, so we'll have to give more time for the exhalation time. Therefore, we have to keep the respiratory rate as low as permissible. On the other hand, if it is ARDS, then sometimes we increase the respiratory rate. Then the rates can be increased on the basis of other things when we will monitor this patient after we have given say mechanical ventilator for starting ventilator for some point of time. Then we'll have to titrate the desired partial pressure of carbon dioxide if possible. And if possible, if you have, then we can use EtCO2 monitoring. The ideal reading will be between 35 to 45. We go ahead. So we have thought about ventilator mode. Okay, suppose we have started, I will keep the child on pressure mode, or I will keep child on volume mode. I will keep this much of rate. Now, if I have chosen volume control, how much tidal volume should I allow? So the main problem, if the main problem is that of hypoxemia, therefore, if the hypoxemia, we have to keep our minute volume high. So we can keep our volume about 6 to 8 ml per kg. 6 to 8 ml per kg. This child we have kept 180 ml. Inspiratory pressure is, so in case we are keeping it pressure control mode, because it's a toddler, the permissible starting inspiratory pressure may be 20 to 22 centimeters of water. But keeping these parameters as independent variable, either volume or pressure, we have to keep in our mind what do we want to achieve, what safety as well as goals. Adequate chest rise should always be there, चाहे वो वॉल्यूम कंट्रोल मोड हो, चाहे वो प्रेशर कंट्रोल मोड हो, दोनों में। जी डॉक्टर पिता, हाँ बोलिए, मैं लेक्चर ले रहा हूँ। हाँ क्या चीज? मैं अभी बाद में बता दूंगी जब लेक्चर पूरा कर लो प्लीज। I'm sorry for the interruption. That was important call to take. I'm sorry. So चाहे हम वॉल्यूम कंट्रोल पे रख रहे हैं, चाहे हम प्रेशर कंट्रोल पे रख रहे हैं, एम एक सबसे पहले हमारी नजर जब हम आते हैं तो मॉनिटर पे ना जाके हमारे पेशेंट पे जानी चाहिए, क्या पेशेंट में चेस्ट राइज हो रहा है या नहीं हो रहा। तो ये वॉल्यूम लिमिटेड, अच्छा एक तो हमने ये देख लिया। दूसरी बात हमारी आनी चाहिए कि सब जब हम मॉनिटर पे देखेंगे तो इंपॉर्टेंट बात ये समझने की, मॉनिटर में एक तो जो बिल्कुल बीच वाला पोर्शन होता है, उसके बाद उसमें एक हॉरिजॉन्टल पट्टी होती है और एक वर्टिकल पट्टी होती है। हमको ये समझना है कि जो हॉरिजॉन्टल फ्लैट पट्टी नीचे नीचे होती है वो पैरामीटर्स हम सेट कर रहे होते हैं, और जो वर्टिकल पट्टी होती है उसमें हमारे उस सेट के खास के हिसाब से रिजल्ट्स आ रहे होते हैं। पिछले घंटे 2 घंटे 3 घंटे के ट्रेंड्स आ रहे होते हैं, या फिर इंस्टेंटली टाइम, बिल्कुल टाइम टू टाइम क्या चेंजेस आ रहे हैं, टाइटल वॉल्यूम डिलीवर्ड कितना हो रहा है या प्रेशर कितना, ये आ रहे होते हैं। ये इंपॉर्टेंट बात है याद रखने की है, हॉरिजॉन्टल वाली पट्टी में हमने क्या सेट किया है या हम सेटिंग चेंज करेंगे, और वर्टिकल पट्टी में जो उसका रिजल्ट होगा वो आएगा। लेकिन सबसे पहले हमको देखना चाहिए, वर्टिकल पट्टी भी अगर हम देख रहे हैं कि एक्सपिरेटरी टाइडल वॉल्यूम कितना है। हम डिलीवर तो कर रहे हैं, डिलीवर करना तो वेंटिलेटर कर रहा है मान लिया, वो पेशेंट तक अगर पहुंचेगा लंग से तभी वो लंग से बाहर निकलेगा। इट इज वेरी इंपॉर्टेंट टू लुक एट एक्सपिरेटरी टाइडल वॉल्यूम। हमारा डिलीवर टाइडल वॉल्यूम तो हमने 180 ml मान लिया, फिक्स कर लिया, हमने वॉल्यूम कंट्रोल मोड रखा, और हमने एक्सपिरेटरी टाइडल वॉल्यूम का जो वर्टिकल वाली पट्टी है उसमें देखा, उसमें आ रहा है 50 ml। बाकी का वॉल्यूम कहां जा रहा है, वो चेस्ट में नहीं पहुंच रहा है। तो हमारा कंसर्न ये है क्या ये लीक हो रहा है या और कोई कॉज है। ठीक है, तो दिस इज वेरी इंपॉर्टेंट व्हाइल डूइंग ऑल दीज एक्सरसाइज। अच्छा, अब अगर हमारा ठीक है, अब हमने पेशेंट का देख लिया चेस्ट राइज हो रहा है, अब हमने देख लिया कि हाँ एक्सपिरेटरी टाइडल वॉल्यूम भी ठीक है। अब हम वॉल्यूम अगर हमने लिमिट किया है तो हमारा, अब हमें क्योंकि प्रेशर मॉनिटर करना है, तो प्रेशर बच्चों के साथ से डेफिनेटली, वैसे तो मैं पीक प्रेशर 30 सेंटीमीटर अराउंड 32 के सेंटीमीटर वाटर के ऊपर नहीं जाना चाहिए, लेकिन बेटर इज टू हैव अ लुक ऑन द प्लेटो प्रेशर। जो प्लेटो प्रेशर होता है वो जब हम वॉल्यूम कंट्रोल में देखते हैं तो पीक आती है, उसके बाद एक नीचे आके थोड़ा सा फ्लैट पोर्शन होता है, वो प्लेटो प्रेशर होता है। प्लेटो प्रेशर इंपॉर्टेंट इसलिए है कि इसमें और कोई चेंजेस डिपिक्ट नहीं होते हैं, ये प्योर एल्वियोलर प्रेशर को डिपिक्ट करता है। क्यों? क्योंकि जब प्लेटो आता है उस समय ना इंस्पिरेशन हो रहा होता है और ना एक्सपिरेशन हो रहा होता है। बर्नौली थ्योरम के हिसाब से अगर कोई भी गैस फ्लो कहीं भी हो रहा है तो ड्यूरिंग दैट गैस फ्लो प्रेशर ड्रॉप होगा, चाहे अक्रॉस दिस एंड और दैट एंड। तो अगर हम प्लेटो प्रेशर देखेंगे तो इसका मतलब ये हुआ कि प्लेटो प्रेशर देखने से फायदा हमारा ये होगा कि हमें एक्चुअल एल्वियोलर प्रेशर देखने को मिलेंगे। हालांकि ये बिल्कुल इसका मतलब ये नहीं कि प्लेटो प्रेशर हमें एल्वियोलर प्रेशर डिपिक्ट कर रहा है, लेकिन इसमें बहुत सारी चीजें जो एयरवेज से हैं, एयरवेज के थ्रू गैस पास होने से जो चेंजेस आ जाते हैं एक्चुअल प्रेशर में, वो डिपिक्ट नहीं होंगे, इसलिए वो है। अगर हम एआरडीएस देख रहे हैं तो उसमें हमारा जो प्लेटो प्रेशर है वो करीब करीब 26 के आसपास होना चाहिए। देन अभी लेक्चर ले रहा हूं प्लीज बाद में, ये प्रेशर लिमिटेड वॉल्यूम, अगर हम प्रेशर को लिमिट किया है तो हमारा मिनिमम वॉल्यूम जितना हम चाहते हैं इतना कम से कम इस बच्चे को टाइडल वॉल्यूम पहुंचना चाहिए, वो हमें हर बार चेक करना होगा। वो जो ग्राफ्स हैं उनमें भी देख सकते हैं, क्योंकि इनमें ग्राफ में जो पीक ऑफ ग्राफ होगा उसके करस्पॉन्डिंग वर्टिकल पे वॉल्यूम वाले में अगर हम देखेंगे तो उसके करस्पॉन्डिंग कितना वॉल्यूम जनरेट हो रहा है हमें ये दिख जाएगा, या फिर हम वर्टिकल वाली पट्टी में डायरेक्ट देख लेंगे रीडिंग कितनी आ रही है। सो चाहे हमने जो भी मोड चूज किया हो, अगर हमने वॉल्यूम मोड चूज किया है तो हमें पीक प्रेशर गॉज करना होगा, अगर हमने प्रेशर मोड चूज किया है तो हमें वॉल्यूम कितना है वो देखना पड़ेगा। टाइडल, अच्छा अब हमें कुल मिला के इन सब, अगर हमें वेंटिलेशन की बात हम कर रहे हैं, कार्बन डाइऑक्साइड की बात कर रहे हैं, तो हमें टोटल मिनट वॉल्यूम ही इफेक्ट करता है, क्योंकि ब्रेथ टू ब्रेथ तो बहुत मुश्किल हो जाएगा। तो 1 मिनट में टोटल वॉल्यूम, तो टोटल वॉल्यूम क्या हो गया, उसको चेंज करने के लिए वेंटिलेशन, अगर कार्बन डाइऑक्साइड रिटेंशन हो रहा है या फिर कार्बन डाइऑक्साइड रिटेंशन ना होकर के वॉश ऑफ हो रहा है, तो हमें मिनट वॉल्यूम को कंट्रोल करना पड़ेगा। उसको कंट्रोल करने के लिए दो पैरामीटर्स होंगे, एक तो टाइडल वॉल्यूम, दूसरा रेस्पिरेटरी रेट। एक तो क्योंकि टाइडल वॉल्यूम इनटू रेस्पिरेटरी रेट इज मिनट वॉल्यूम, तो मिनट वॉल्यूम एडिक्वेट होना चाहिए। अगर हमारा वॉश आउट हो रहा है तो हमें मिनट वॉल्यूम थोड़ा सा कम कर सकते हैं, चाहे हम टाइडल वॉल्यूम कम करके करें, चाहे हम रेस्पिरेटरी रेट कम करके करें। अगर हमें मिनट वॉल्यूम बढ़ाना है तो हम टाइडल वॉल्यूम भी एक लिमिट तक बढ़ा सकते हैं, और इसी तरह हम रेस्पिरेटरी रेट भी एक लिमिट तक बढ़ा सकते हैं। ओके, अब हमारी अगली चीज आती है, हमने इंस्पिरेटरी। प्लीज जस्ट एक्सक्यूज, कौन है भाई? अरे मैं काम कर रहा हूँ, प्लीज। I'm sorry the interruptions. Okay, inspiratory time. तो इंस्पिरेटरी टाइम का यूजुअल फिजियोलॉजिकल जो इंस्पिरेशन और एक्सपिरेशन का रेशियो होता है, वो इंस्पिरेशन कम होता है, और एक्सपिरेशन चूंकि पैसिव प्रोसेस होता है तो उसमें समय ज्यादा लगता है चेस्ट की कंप्लायंस के हिसाब से। यहाँ पे चेस्ट की कंप्लायंस में लंग की कंप्लायंस प्लस चेस्ट वॉल की कंप्लायंस, जिसमें सारी चीजें आती हैं, चेस्ट वॉल, बोन्स, मसल्स, इन सब की कंप्लायंस कुल मिलाकर के आती है। तो ये करीब करीब, इसलिए एक्सपिरेटरी टाइम 2 से 2.5 गुना ज्यादा होता है। इसलिए हमारा इंस्पिरेटरी टाइम हम इतना रखें टोटल रेट के हिसाब से कि उसका रेशियो करीब 1:2 से लेके 1:2.5 के बीच में आना चाहिए। इंपॉर्टेंट बात यह है कि जैसे बड़े समझने की बात है कि अगर हमने 20 रेस्पिरेटरी रेट रखी है तो 20 का मतलब ये हो गया कि एक साइकिल जो सांस की होगी उसको 3 सेकेंड्स मिलेंगे। तो अगर हमें 1:2 IE रेशियो रखना है तो हमें 1 सेकेंड का रेस्पिरेटरी टाइम डालेंगे, बाकी बचा हुआ 2 सेकेंड एक्सपिरेशन के लिए हो जाएगा। तो ये IE रेशियो 1:2 विच इज फिजियोलॉजिकल से जो I:E रेशियो है वो हो जाएगा। लेकिन कई बार इसको हमको चेंज करना पड़ता है। यंगर द चाइल्ड शॉर्ट द आई टाइम, तो क्योंकि रेट बढ़ती जाती है। 1 साल से बच्चे में TI की रेंज 0.6 to 0.8 होती है, 1 से 5 में 0.8 to 1 seconds, 5 to 12 years 1 to 1.2 seconds, and more than 12 years 1.2 to 1.5 seconds. So ये चूंकि डिपेंड करती है रेस्पिरेटरी रेट, जितनी ज्यादा रेस्पिरेटरी रेट हो जाएगी, एक सिंगल रेस्पिरेशन के लिए टाइम कम बच जाएगा। ओके, तो ये बात होगी हमारी। अब हमारी कितनी ऑक्सीजन से शुरू करना चाहिए, इसमें कई सारी चीजें यूजुअली हमको ये जानना चाहिए। हम जानते हैं कि ऑक्सीजन एक ड्रग है, ये नुकसान भी पहुंचाती है, ये बात हमें अच्छे से समझनी चाहिए। तो हम मिनिमम पॉसिबल ऑक्सीजन मिनिमम समय तक देना चाहते हैं, लेकिन उतना तो दें कि अगर हाइपोक्सिया जो हो रहा है वो तो कंट्रोल हो। तो कुछ लोग 100 से हालांकि शुरू तो करते हैं, लेकिन क्विकली बेड साइड रह के, आसपास रह के, क्विकली जल्दी जल्दी पेशेंट की कंडीशंस को मॉनिटर करते हुए धीरे धीरे इसको एम होता है कि 0.5 के आसपास जरूर ले आए। इन दिस चाइल्ड डेफिनेटली हमने करीब करीब 0.7 से स्टार्ट किया, और टाइट्रेट अब हम करेंगे SpO2 के हिसाब से इनिशियली, PO2 अभी बाद में, क्योंकि बार बार हम PO2 नहीं कर सकते हैं। और SpO2 हमारा 92 to 95% के बीच में रहना चाहिए। ये हम पहले टॉक्स में काफी पढ़ चुके हैं, ठीक है। अब बात आती है वन ऑफ द मोर इंपॉर्टेंट, सभी इक्वली इंपॉर्टेंट है, पीप की बात आती है। पीप स्टार्ट, ये जनरलाइजेशन तो जरा मुश्किल सा है कि स्टार्ट विद एटलीस्ट 7 to 8 सेंटीमीटर ऑफ वाटर एज ही इज हाइपोक्सीमिक, टाइट्रेट सब्सिक्वेंटली। हाउ टू टाइट्रेट, नियोनेट है तो कम होगा, लेकिन मिनिमम ये समझना चाहिए हमें पीप 5 सेंटीमीटर रखनी है। अगर साथ में COPD जैसी चीज तो कम होती बच्चों में, अगर ब्रोंकियल अस्थमा या ब्रोंकियोलाइटिस के लिए हम कर रहे हैं तब फिर हमें पीप को कम रखना पड़ेगा, क्योंकि इन कंडीशंस में हो सकता है कि एयर ट्रैपिंग हो रही हो, तो थोड़ी ऑटो पीप वैसे ही जनरेट हो रही हो। इसलिए हमें पीप को 5, 3, 2 इवन 1 तक कई बार हम रखते हैं सीवियर ब्रोंकियल अस्थमा के केसेस में। सो जनरलाइजेशन इज मोस्ट ऑफ द टाइम, तो वैसे भी साइंस में 2 and 2 में भी 4 and 2 and 2 में भी 400, लेकिन प्रॉपर अंडरस्टैंडिंग चाहिए। अगर हमें हाइपोक्सीमिया को डील करना है और हाइपोक्सिया होता चला जा रहा है तो हम डेफिनेटली पीप हमारी ज्यादा रखेंगे, क्योंकि पीप क्या करती है, हमारे एल्वियोलाई को सरफेस टेंशन बढ़ाती है, और उनके चारों जो कैपिलरी हैं, क्योंकि ज्यादा सरफेस एक्सपोज हो जाती है कैपिलरीज को, तो ज्यादा गैस एक्सचेंज होने लगता है। ये बड़ा सिंपल सा मैंने कह दिया, लेकिन इसमें बहुत सारे फैक्टर्स होते हैं, क्योंकि बहुत ही ज्यादा पीप बढ़ाने पे वो इतना ज्यादा प्रेशर एल्वियोलस में हो सकता है कि उसके चिपकी हुई जो कैपिलरीज हैं वो इतनी दब जाएं कि प्रेशर की वजह से वहां पे फ्लो ही बंद हो जाए ब्लड का, तो वीक्यू मिसमैच हो जाएगा। इसलिए टाइट्रेट हम इसको करते हैं और धीरे धीरे टाइट्रेट करते हैं। पीप को ऑप्टिमाइज इसीलिए करना बहुत जरूरी है। पीप फायदेमंद भी है, पीप डेट्रीमेंटल भी है। फायदे क्या है, जैसे हमने अभी बात करी, इट रिक्रूटमेंट का मतलब होता है कि एट वन पॉइंट ऑफ टाइम इवन फिजियोलॉजिकली 100 के 100% एल्वियोलाई बिल्कुल भी पूरी तरह गोल गोल खुले हुए नहीं होते हैं। कुछ कम खुले हुए होते हैं, कुछ थोड़े से ज्यादा खुले हुए होते हैं। जब उनमें एयर जाती है तो वो खुलते हैं, और बंद होने के बाद में एक डेफिनेट लेवल पे उनको आना चाहिए, क्योंकि गुब्बारे की तरह अगर वो चिपक जा रहे हैं तो फिर जैसे कि हम जानते हैं कि गुब्बारा बिल्कुल, जैसे कई बार हम उसको निगेटिव प्रेशर देके जब हवा निकाल देते हैं तो दोनों उसकी लेयर चिपक जाते हैं, फिर हम उसको फूंक के सुखाने में हमें ज्यादा ताकत लगती है। दो गीली स्लाइड टच कराते हैं तो उनको अलग करने में बहुत ताकत लगती है। इसलिए हम इतना चाहते हैं कि पीप इतनी रहे, जिसका उल्टे कहने का मतलब कि हमारे एवरेज नंबर ऑफ एल्वियोलाई इतने फूले हुए रहें कि जब हम उनको फिर से और ज्यादा उनको फुलाना चाहें तो फिर उतना प्रेशर, उतना टाइम ना लगे। तो रिक्रूटमेंट का मोटा क्रूड मतलब ये हुआ, और जितने ज्यादा रिक्रूटेड होंगे, यानी कि जितने ज्यादा एल्वियोलाई ऑक्सीजन या गैस एक्सचेंज में पार्टिसिपेट कर रहे होंगे, उतना ज्यादा ऑक्सीजन के लिए, ऑक्सीजन एब्जॉर्प्शन के लिए मदद मिलेगी। इसीलिए ज्यादा खुले रहेंगे तो कंप्लायंस अच्छी होगी। कंप्लायंस ज्यादा प्रेशर लगाना पड़ेगा अगर कुछ एल्वियोलाई चिपके हुए हैं, तो जितने ज्यादा एल्वियोलाई बिल्कुल पूरी तरह से चिपके हुए नहीं हैं, उनको फुलाने के लिए कम हमें प्रेशर लगाना पड़ेगा। दैट मीन्स कि ये कंप्लायंस बेटर करती है। और एटिलेक्टोट्रॉमा नहीं होता चिपक करके कुछ दोबारा खुलने में, कुछ की तो क्या कहते हैं, जो एपिथेलियम है वही खराब हो जाती है। तो वो प्रॉब्लम, अगर कोई एल्वियोलाई बिल्कुल ही आपस में नहीं चिपक जाएंगे तो वो बिल्कुल इस तरीके से करेंगे, ना कि ऐसे करके फिर खोलने में कुछ टूट जाते हैं। ठीक है, तो ये फायदे हैं पीप को ऑप्टिमम पीप रखने के: रिक्रूटमेंट, बेटर कंप्लायंस एंड प्रिवेंटिंग एटिलेक्टोट्रॉमा। एडवर्स इफेक्ट्स भी होते हैं पीप के। क्या होते हैं? एक्सेसिव पीप कॉजेस डिक्रीज वीनस रिटर्न। कैसे? कि देखिए, मैकेनिक्स तो हमें मालूम ही है, मैकेनिकल वेंटिलेशन में कुछ इफेक्ट्स होते हैं। नॉर्मल फिजियोलॉजी में क्या होता है कि जब एक नेगेटिव प्रेशर सिस्टम है, डायफ्राम नीचे पुश डाउन हुआ तो उसने नेगेटिव प्रेशर कराया, प्लूरल कैविटी में नेगेटिव प्रेशर हुआ, उसकी वजह से एयरवेज में सक इन ऑफ एयर इनटू द लंग्स आ गई। लेकिन साथ में ही सेम नेगेटिव इंट्राथोरेसिक प्रेशर डिक्रीजेस द राइट एट्रियल प्रेशर and generates a sucking effect on the inferior vena cava। इसलिए इस नेगेटिव प्रेशर की वजह से वीनस रिटर्न बढ़ जाता है। लेकिन मैकेनिकल वेंटिलेशन जब हम कर रहे हैं तो हम इसके अगेंस्ट प्रेशर हम बढ़ा रहे हैं। इसका मतलब तो वैसे ही वीनस रिटर्न अगर कम है और हमने प्रेशर बढ़ा दिया राइट एट्रियम में, तो फिर हमारे अब जो हार्ट कॉन्ट्रैक्ट करेगा वो कम वॉल्यूम आ पाएगा। कम वॉल्यूम राइट लंग में आने की वजह से जो स्टार्लिंग्स लॉ का जो कंफर्टेबल जोन है वहां पे हार्ट कॉन्ट्रैक्ट नहीं कर पाएगा। इसलिए हमें पीप को ऑप्टिमल रखना चाहिए। एक्सेसिव पीप देयरफॉर कैन कॉज डिक्रीज वीनस रिटर्न, जो कि हमें खासतौर से शॉक और इन सब के पॉसिबल केसेस में या ऐसी कंडीशन जिनमें शॉक हो सकता है वो नहीं होंगे। देन हाइपोटेंशन हो सकता है, इसी वजह से वीनस रिटर्न कम हुआ, हाइपोटेंशन हो सकता है, और अगर बहुत ज्यादा पीप हो गई तो बैरोट्रॉमा हो सकता है। तो ये 3 नुकसान है। ओके, अब क्या अदर सेंसिटिव? ट्रिगर सेंसिटिविटी। फ्लो सेंसिटिव, फ्लो हमें ट्रिगर लगाना चाहिए या प्रेशर ट्रिगर लगाना चाहिए? देखिए, जो वेंटिलेटर है या जो सॉरी जो दो एक तो जब भी रेस्पिरेशन होता है तो उसमें ये हमें मालूम है कि हेयरिंग ब्रूअर रिफ्लेक्स होता है। दो तरीके की, एक तो जो सीएनएस में है वो कीमो रिसेप्टर्स होते हैं और वो हर बार पीएच को फील करते हैं, और जो मसल्स होती हैं वो हर बार स्ट्रेच को फील करती हैं। तो ये दोनों स्ट्रेच रिसेप्टर्स और कीमो रिसेप्टर्स इन ब्रेन मिल करके टाइडल वॉल्यूम एंड रेट डिसाइड करते हैं। तो जब हम गैस अंदर जरा सा भी गैस फ्लो होगा तो सबसे पहले फ्लो को मेजर कर लेते हैं स्ट्रेच रिसेप्टर्स। प्रेशर चेंज, फ्लो कुछ हो चुकेगा तभी ना फ्लो के बाद प्रेशर चेंज होगा। बर्नौली थ्योरम के हिसाब से पहले फ्लो होगा और उसके बाद जब वो इतना फ्लो हो जाए कि वो कुछ प्रेशर चेंज जनरेट कर सके। इसलिए फ्लो ट्रिगर्स आर डेफिनेटली इजियर and comfortable for the patient to take breathe instead of pressure triggers. May not have any meaning in initial setting. Initial तो हमने डाल दी, उसके बाद हम जब हायर सेटिंग्स पे अगर या चेंज इन द सेटिंग्स हमें करना होता है तब जाते हैं। फ्लो ट्रिगर ऑफ 2 to 4 इज अप्रोप्रिएट। राइज टाइम क्या चीज है? जैसे मान लिया हमने टोटल हमारा रेट ऑफ इनगोइंग एयर एंड ऑक्सीजन मिक्सचर, उसका पहले हमें हल्के से स्पीड से शुरू हुआ, उसके बाद हाईएस्ट स्पीड पे पहुंच गया। कितनी देर में मिनिमम स्पीड से हाईएस्ट फ्लो ऑफ गैस पहुंच गया, वो राइज टाइम कहलाता है। उसके बाद अगर वॉल्यूम कंट्रोल है तो वो मैक्सिमम वो राइज होता रहेगा। तो 5 to 10% राइज टाइम ऑफ द इंस्पिरेटरी टाइम इज थॉट टू बी एडिक्वेट। तो प्रेशर कंट्रोल में हमने डाला मान लीजिए, और पीआईपी 22 सेंटीमीटर ऑफ वाटर रखा, पीप हमने 8 सेंटीमीटर ऑफ वाटर रखा, रेस्पिरेटरी रेट हमने 18 पर मिनट रखा, आईई रेशियो 1:2 रखा, FiO2 0.8 अब कर दिया हमने 80%, एंड ट्रिगर अभी हमने कोई नहीं रखा, अभी हमें चाहिए ही नहीं पेशेंट को ब्रीथ करने के लिए कुछ। सिडेशन अब हमने स्टार्ट कर दिया, मिडाजोलैम एंड और फेंटेनिल और मॉर्फिन। देखिए फॉरेन बॉडी इनसाइड द ट्रैकिया, जरा सा धूल चली जाती है तो कितनी जोर की खांसी आती है। तो सिडेशन ऑलमोस्ट इज मस्ट। पेशेंट को हम ये ना समझेगा रहे तो ठीक है, सिडेशन हमें देना चाहिए, क्योंकि फॉरेन बॉडी लगातार लंग्स में पड़ी हो ये बड़ी तकलीफ दे चीज होती है। हम मॉनिटर क्यों करते हैं? वाइटल साइंस, हार्ट रेट एंड रेस्पिरेटरी रेट को इंप्रूव करना चाहिए, तभी तो हमें पता चलेगा कि हमारे मैकेनिकल वेंटिलेटर से लेशन से फायदा हो रहा है या नुकसान हो रहा है। तो यूजुअल अगर हार्ट रेट नॉर्मल से ज्यादा थी तो उसे नॉर्मल की तरफ आना चाहिए, और कम थी तो भी नॉर्मल की तरफ आना चाहिए। रेस्पिरेटरी रेट अगर कम थी तो उसे नॉर्मल की तरफ रिपीट करना चाहिए, और ज्यादा थी तो उसे नॉर्मल की तरफ वापस आना चाहिए। ब्लड प्रेशर अगर कम था तो उसे इंप्रूव होना चाहिए हाइपोक्सिया की वजह से, अगर बहुत ज्यादा था तो फिर उसे नॉर्मल की तरफ आना चाहिए। सिडेशन से ब्लड प्रेशर कम हो सकता है तो हमें इसका ध्यान रखना है, ठीक है। चेस्ट राइज हमें जरूर देखना है, चेस्ट राइज हो रहा है, बहुत ज्यादा तो नहीं हो रहा है, बहुत कम तो नहीं हो रहा है, और बाइलेटरल हो रहा है, कहीं एक ही तरफ तो नहीं हो रहा है, कहीं न्यूमोथोरेक्स तो नहीं बन गया, एंड बाइलेटरल एयर एंट्री है कि नहीं है। देन SpO2 कितना है, और अगर हमारे पास EtCO2 है तो वो नॉर्मल रेंज में आ रहे हैं कि नहीं। वेंटिलेटरी पैरामीटर्स जो हमें वॉच करने हैं, टाइडल वॉल्यूम हमें देखना है। अगर हमने क्योंकि हमने इसको प्रेशर कंट्रोल पे रखा है 22 पे, तो हमें टाइडल वॉल्यूम जनरेटेड देखना है कितना है, चाहे हम ग्राफ में देखें चाहे जो वर्टिकल पट्टी है उसमें देखें। इंस्पिरेटरी एंड एक्सपिरेटरी जैसे कि हम लोग कहते हैं वैसे वो जरूरी देखना है। पीक अगर हमने वॉल्यूम कंट्रोल पे रखा है तो पीक प्रेशर देखना है और मीन एयरवे प्रेशर देखना है। मिनट वॉल्यूम कितना हो रहा है, अगर हम इंटरेस्टेड हैं कार्बन डाइऑक्साइड में तो फिर हमें मिनट वॉल्यूम को मैनिपुलेट करके या तो रेस्पिरेटरी रेट या टाइडल वॉल्यूम या दोनों को मैनिपुलेट करके इस लेवल में रहना होगा कि कार्बन डाइऑक्साइड हमारी नॉर्मल रेंज है। अब मान लीजिए हमारा कोविड-19 का पेशेंट ARDS का पेशेंट है, अब उसमें CO2 मान लिया 70-80 आ रही है, तो परमिसिव हाइपर कैप्निया के अगेंस्ट अगर हमारा pH 7.2 से लेकर 7.25 से ऊपर है तो हम उतनी कार्बन डाइऑक्साइड टॉलरेट कर सकते हैं। इसको हम बोलते हैं परमिसिव हाइपरकैप्निया। अगर हमारा पीएच चेंज नहीं हो रहा है इतना, तो फिर हम उसको टॉलरेट करेंगे। मिनट वाइज, क्योंकि मेनली तो एआरडीएस जो है, मेनली तो हाइपोक्सिया ही है जो कि हमें नुकसान पहुंचा रहा है एआरडीएस में। इसके बाद हम वेव फॉर्म्स देखते हैं। एबीजी को हमें मॉनिटर करना होता है। डू नॉट एम फॉर बिल्कुल हमें ये नहीं कि जैसे वो एक कहावत नहीं होती थी, घर भर के बदल डालूंगा एक खराब हो तो। नॉर्मल ब्लड गैस हमें टुवर्ड्स नॉर्मल होना चाहिए, बिल्कुल ही एब्सोल्युटली अब नॉर्मल ना हो। वी शुड एम एट टुवर्ड्स नॉर्मल ब्लड गैस इंस्टेड ऑफ कंप्लीटली नॉर्मल पैरामीटर्स। हमने स्टार्ट कर लिया, अब हम मॉनिटर करना शुरू कर दिया। अब हाउ टू ऑप्टिमाइज वेंटिलेशन। ऑप्टिमाइज करने की जरूरत कब है? वाइटल साइंस जैसे थे वो या तो इंप्रूव नहीं हो रहे हैं और गड़बड़ा गए हैं, तो फिर सेटिंग्स या तो सही नहीं है या पेशेंट इज अंडर सीडेटेड। जैसे कि हम लोग बात कर रहे थे, ये फॉरेन बॉडी अंदर होना बहुत बड़ी चीज होती है, तो पेशेंट फाइट कर रहा है, या फिर फीवर की वजह से उसकी रिक्वायरमेंट्स डिफरेंट हो गई है, या फिर सीक्रीशंस बढ़ रहे हैं, तो चेस्ट में बढ़ रहे हैं या इवन ट्यूब में बढ़ रहे हैं, जो कि वेंटिलेशन से और पूरे सिस्टम के कंप्लायंस से इंटरफियर कर रहे हैं। चेस्ट राइज हमें देखनी पड़ेगी, एडिक्वेट नहीं है। अगर इनएडिक्वेट है तब हमें ऑप्टिमाइज करना पड़ेगा, या तो हम पीआईपी इंक्रीज करें या फिर कॉज ढूंढे कहाँ है, लुक फॉर द किंग्स और लीक। देखिए चेस्ट राइज अगर नहीं हो रहा है तो सबसे इंपॉर्टेंट पार्ट ये है कि हमेशा यही हम पेशेंट में ही गलती ना ढूंढे, हमें ये भी देखना है कि हमारा वेंटिलेशन क्या हो रहा है। तो एक इंपॉर्टेंट बात समझने की ये है कि अगर हमारा चेस्ट राइज नहीं हो रहा है और ये अभी तो SpO2 ठीक था, अब कम होने लगा, तो बहुत ज्यादा फाइट करने से सबसे पहले हम क्या कर सकते हैं, पेशेंट को हम फट से हटा के टेस्ट लंग पे तो वेंटिलेटर को लगा दिया और पेशेंट को वेंटिलेटर अम्बू बैग पे ले गया। अगर अम्बू बैग लगाने के बाद चेस्ट लंग बिल्कुल चेस्ट राइज ठीक हो रहा है और नॉर्मल वेंटिलेशन देने पे, नॉर्मल थोड़ा थोड़ा अम्बू दबाने पे और SpO2 इंप्रूव होना शुरू हो गया, इसका मतलब गड़बड़ या तो बाहर है, या तो रेस्पिरेटरी ट्यूब में कुछ गड़बड़ है, या फिर वेंटिलेटर की सेटिंग्स में या वेंटिलेटर में गड़बड़ है। लेकिन अगर इसमें पेशेंट तब भी नहीं इंप्रूव हुआ तो इसका हमारी वेंटिलेटर की सेटिंग बिल्कुल ठीक थी, हमें अब सेटिंग्स चेंज करनी पड़ेंगी क्योंकि पेशेंट के कंप्लायंस चेंज हो रहे हैं, या फिर ट्यूब जो पेशेंट के अंदर जा रही है वो ब्लॉक है या किंक है, या फिर सेडेशन का में पेशेंट ऐसा होता नहीं ट्यूब को कस के चबाए हुए है, बाकी सब ठीक है, दांतों के बीच में बीजे हुए है तो हो ही नहीं पा रहा है, अंदर गैस ही नहीं जा पा रहा। अगर एक्सेसिव चेस्ट राइज हो रहा है तो हमें डिक्रीज करना पड़ेगा पीआईपी को। तो SpO2 अगर 92% से कम है, अगर 10 हमारी सेटिंग चेंज करने के बाद 10-15 मिनट भी हो गए तो हम देखेंगे FiO2 बढ़ाएं, या फिर FiO2 जब स्टेबलाइज होने लगे तो फिर देखिए SpO2 की जब हम बात कर रहे हैं इसका मतलब SpO2 यानी, तो हम बात कर रहे हैं FiO2 एंड ऑफ कोर्स दी पीप, इन दोनों के इंटरेक्शन की। आइडियली क्या है, क्योंकि ऑक्सीजन नुकसान करती है तो शुरुआत में तो हम FiO2 ज्यादा रखते हैं, लेकिन अगर बीच में भी हमारे गड़बड़ होती है तो हम पहले पीप बढ़ा लेते हैं, इवन 7, 8, 9, 10 तक बढ़ा लेते हैं, इसके बाद और FiO2 बढ़ा लेते हैं। इसके बाद पहले हम FiO2 कम करते चले जाते हैं, FiO2 करीब 50 के आसपास हो जाए और अभी भी हमारा सब कुछ ठीक है, अब हम पीप घटाना शुरू करते हैं। तो हमारी प्रीवेलेंट जो ज्यादा इंपॉर्टेंस दी जाती है लेटर ऑन, वो हमारी लंबे समय तक के लिए FiO2 50 या उसके नीचे रहे, इसको दी जाती, भले ही हमें थोड़ी ज्यादा पीप देनी पड़ रही है। SpO2 99 to 100% हमें नहीं एम करना चाहिए। अगर 99 और प्रीडोमिनेटली 100 के आसपास रह रही है तो हमारा मौका है कि हम FiO2 कम करें, और अगर हम FiO2 कम कर चुके हैं, FiO2 50 ही है, तो अब हमें चाहिए कि अगर पीप ज्यादा है तो पीप को कम करना शुरू करें। टाइडल वॉल्यूम कम आ रहा है या मिनट वॉल्यूम कम आ रहा है तो हम पहले PIP बढ़ा के देख सकते हैं, ट्यूबिंग्स में कहीं लीक तो नहीं हो रही है, एक्सपिरेटरी टाइडल वॉल्यूम जैसे हमने बात किया वो देख सकते हैं, कंप्लायंस पुअर तो नहीं हो रही है, निमोनिया तो नहीं डेवलप हो गया, वैप तो नहीं डेवलप हो गया, या न्यूमोथेरेक्स तो नहीं डेवलप हो गया, ये चीज हमें देखनी पड़ेगी। सडन राइज इन पीक प्रेशर अगर हो गया है, कॉज क्या हो सकते हैं, जैसे कि अभी पीछे आपने पढ़ा DOPE, डोप, सिक्रीशंस, ब्रोंकोस्पैज्म, किंक इन ट्यूब, सक्शन करना चाहिए और नेबुलाइजेशन करना चाहिए कि कहीं ऐसा तो नहीं ब्रोंकोस्पैज्म नहीं हो रहा हो. Sometimes even the presence of tube can give rise to bronchospasm because it works as a foreign body. Ensure patient is not biting the tube, इसकी हम बात कर चुके हैं पहले. अब हमारी टारगेट क्या होना चाहिए ब्लड गैसेस को? हमने पेशेंट देख लिया, हमको सबको मालूम है कि हमारा भाई 7.35 ना हो तो 7.3 हो और 7.45 ना हो, क्योंकि हमारी नॉर्मल रेंज तो पीएच की 7.35 से लेके 7.45 होती है. थोड़ा सा हम अलाउंसेस रख सकते हैं, पीएच हम 7.3 से लेकर 7.5 तक टॉलरेट कर सकते हैं. AO2 आर्टीरियल ब्लड गैसेस में 55 to 80 यानी कि मॉडरेट लेवल तक हम टॉलरेट कर सकते हैं. PaCO2 नॉर्मल 45 होता है, लेकिन हम 55 तक हम ठीक है, हम सोचते हैं कि अभी टाइम है, ठीक हो जाएगा. लैक्टेट लेवल कुछ लोग 2 कहते हैं, कुछ लोग 4 कहते हैं, लेकिन नॉर्मल जो बेस लाइन है उसके पास आने की कोशिश करनी चाहिए. 2 से ऊपर है सावधान हो जाइए, 4 से ऊपर जरूर कहीं ना कहीं कोई गड़बड़ है तो हमें देखना चाहिए. क्या हमारा पीप तो बहुत ज्यादा नहीं है जिससे कि शॉक में पेशेंट जाने लगा है, रिटर्न ही कम हो रहा है, या फिर और कोई कॉज है, या फिर सेप्सिस है. इलेक्ट्रोलाइट्स, सोडियम, खासतौर से पोटेशियम, मैग्नीशियम एवं फास्फोरस नॉर्मल होने चाहिए. ऑन्कोलॉजी का अगर पेशेंट है तो हमें फास्फोरस पे और पेशेंट पे ज्यादा ध्यान देना होगा. अगर बहुत ही मोरिबंड सा पेशेंट है तो हमें मैग्नीशियम और कैल्शियम पे ज्यादा ध्यान देना होगा. ब्लड गैसेस को हम ऑप्टिमाइज कैसे करें? लो PaO2 अगर आ रहा है मान लिया उसमें, तो ऑक्सीजनेशन इंप्रूव करने की हम बात कर चुके हैं. ये 2 चीजों का इंटरप्ले है, पीप एंड FiO2. सबसे पहले हम पीप को, सबसे पहले बीच में अगर करना है तो हम पीप को बढ़ा के देख लेते हैं. अगर 50 के आसपास ही FiO2 पे हमारा थोड़ा पीप बढ़ाने से काम चल जाता है तो ठीक है. हम बहुत ज्यादा पेशेंट को लंबे समय तक फ्री रेडिकल इंजरी ऑक्सीजन से नहीं देना चाहते, लेकिन अगर FiO2 बढ़ाई है तो फिर हम उसे टाइम के रहते जब पेशेंट हम कंफर्टेबल लगता है, PaO2 नॉर्मल आने लगती है, तो हम जल्दी से जल्दी कम से कम 50 के नीचे लाना चाहते हैं. पोजीशन चेंज करके देख सकते हैं ARDS का अगर पेशेंट है तो, लेटरल एंड प्रोन. लेकिन प्रोन करना मैकेनिकली वेंटिलेटेड पेशेंट में उतना इजी नहीं है, ये अलग टॉपिक है, लेकिन प्लीज करने से पहले इसके सीनियर से और दूसरे लोगों से और लिटरेचर से देख लें. अभी परव्यू नहीं है हमें प्रोन वेंटिलेशन डेवलप करने का, और प्रोन वेंटिलेशन जादू की छड़ी नहीं है. जब से करते हैं तो 12, 16, 18, 24, 23 घंटे, 36 घंटे तक कई बार रखते हैं अगर वाकई ARDS है तो. अगर वेंटिलेशन गड़बड़ है, इसका मतलब PaCO2 गड़बड़ है आर्टीरियल ब्लड गैसेस में, तो उसका इंटरप्रेट हमें मिनट वॉल्यूम चेंज करके करना होता है, जो हम अभी बात कर चुके हैं. टाइडल वॉल्यूम बढ़ा के घटा के, रेस्पिरेटरी रेट बढ़ा के घटा के, दोनों का इंटरेक्शन उस सिस्टम में होता है. अगर इनसे नहीं इंप्रूव हो रहा है तो कारण कहीं ब्रोंकोस्पैज्म तो नहीं हो रहा है, कहीं सिक्रीशंस तो नहीं है, कहीं डेड स्पेस बढ़ तो नहीं गया है, ट्यूब साइज बहुत ज्यादा तो नहीं है, फिजियोलॉजिकल डेड स्पेस के अलावा पैथोलॉजिकल डेड स्पेस बहुत ज्यादा नहीं है. ठीक है. इंक्रीज एक्सपिरेटरी टाइम कई बार हमें बढ़ाना पड़ता है इन दोनों के बाद में, कि हमें भाई एक्सपिरेशन जैसे कि ब्रोंकियल एस्मा में हम करते हैं टाइम में. अलार्म सेट करना बड़ा जरूरी है. हमारे रेजिडेंट ज्यादातर अलार्म सेट करना भूल जाते हैं. रेस्पिरेटरी रेट, हाई एंड लो, टाइडल वॉल्यूम, जितना भी आपने मिनट वॉल्यूम बनाया, टाइडल वॉल्यूम बनाया है उसका 10% ज्यादा वो हायर और 10 to 15% लोअर रखना चाहिए. मिनट वॉल्यूम का 10%, 15% हायर एंड 10 to 15% लोअर जरूर अलार्म लगाना चाहिए. हमें पता ही नहीं लगेगा कि पेशेंट को जितना हमने चाहा है उतना वॉल्यूम डिलीवर हो रहा है, नहीं हो रहा है, या उससे ज्यादा हो रहा है, बैरोट्रमा हो रहा है. इंस्पिरेटरी प्रेशर, पीक एंड लो दोनों की हमें लिमिट्स डालनी होती है. वो अपने आप जब हम अलार्म वाला सेट करते हैं तो अपने आप वहां पे 5 पैरामीटर्स होते हैं जो हमें सेट करने होते हैं, अपर लिमिट, लोअर लिमिट. FiO2 लो एंड हाई वो हमारे पैरामीटर्स में नहीं होती है, लेकिन हमें खुद करनी होती है. पीप, हाई एंड लो. तो स्किल्स टू बी लर्नड एंड रिटेन्ड क्या होनी चाहिए? हाउ टू स्टार्ट, व्हाई टू स्टार्ट, हाउ टू स्टार्ट invasive ventilation in a hypoxemic child who is not improving on NIV. एक सेट रूल ये है कि 2 घंटे ज्यादा नॉन इन्वेजिव वेंटिलेशन पे अगर पेशेंट इंप्रूव नहीं हो रहा है तो हमें उसे मैकेनिकल वेंटिलेशन पे डालना चाहिए, नहीं तो पेशेंट फटीग में जाने का इरिवर्सिबल कुछ चेंजेस आते हैं. अब हमने सक्सेसफुली चूज कर लिया, सारे पैरामीटर चूज कर लिया, भाई मैंने चूज कर लिया मैं प्रेशर कंट्रोल या वॉल्यूम कंट्रोल मोड पर डालूंगा। शुरुआत में मैं FiO2 100% रखूंगा, फिर धीरे धीरे से कम करूंगा। मैं इसकी पी 5 रखूंगा। मैं इसका टाइडल वॉल्यूम, मान लिया मेरा 15 kg का बच्चा है तो मैं 8 से दूंगा, ना कि 6 से, क्योंकि ARDS नहीं है, 120 या ARDS है। तो एक इंपॉर्टेंट चीज इस स्लाइड में थोड़ा सा सॉरी मिसिंग है, क्योंकि ओबीज बच्चे की हमने बात करी थी। ये वाली स्लाइड प्लीज देखिए, कहाँ गया ये वाला बच्चा, सॉरी ये यहाँ पे ओबीज लिखा हुआ है। बड़ी इंपॉर्टेंट बात है कि जब हम टाइडल वॉल्यूम सेट करने वाले हैं, कहाँ गया टाइडल वॉल्यूम, ये इंपॉर्टेंट बात है, ओबीज हो या ना ओबीज हो, ये हमें आइडियल बॉडी वेट के हिसाब से कैलकुलेट करना है। ये बात गांठ बांध ली। कई बार ऐसा होता है कि पता चला हमारा, अभी हमारे यहाँ एक 4 साल का बच्चा 45 kg का था, तो उसमें इसका मतलब ये नहीं कि 45 × 6 उसका हम टाइडल वॉल्यूम रखें। उसका आइडियल बॉडी वेट जितना होना चाहिए, टाइडल वॉल्यूम उससे ही रखा जाएगा, नहीं तो बैरोट्रोमा हो जाएगा। ठीक है, तो ये इंपॉर्टेंट बात थी इसकी। तो हाउ टू स्टार्ट में आइडियल बॉडी वेट, अपने अपने प्रिपरेशन में प्लीज जिसको चेंज कर लें। टाइडल वॉल्यूम इज 6 to 8 लीटर पर मिनट और मोर और लेस पर 6 to 8 liters पर kg पर ऑफ आइडियल वेट, आइडियल बॉडी वेट करना होगा। हाउ टू मॉनिटर अ चाइल्ड हु हैज बीन स्टार्टेड ऑन इनवेसिव वेंटिलेशन, ये हमने बात की। ईच ऑफ, इसमें क्लिनिकल भी पैरामीटर्स इंपॉर्टेंट हैं और वेंटिलेटर वाले भी इंपॉर्टेंट हैं, और बायोकेमिकल या एयर आर्टीरियल ब्लड गैसेस की पैरामीटर भी इंपॉर्टेंट है। हाउ टू ऑप्टिमाइज ऑक्सीजनेशन एंड वेंटिलेशन कंसीडरिंग ऑल मॉनिटर्ड पैरामीटर्स, और इसके बाद every time if we keep on reading, that means we will keep on learning more and more. So that is all from my side. Any questions? So we can discuss. In case I am not able to answer, you can have my number and we can always discuss later on.
Thank you, Dr. Siddharth. You have explained everything so nicely and in a simple manner. So thank you very much, and I don't see there is any question related to your talk.
Yes, ma'am.
So thank you. So now
Thank
we
you, ma'am.
move to the last talk of that day. So that will be taken by Dr. Aisha Ahmed, and she is from AMU Aligarh.
So I will stop sharing.
Yeah, and she will be talking about the weaning and extubation. So our child has improved now, and child is fit for weaning. So I welcome Dr. Aisha.
Thank you, Dr. Chandrakanta.
And I request, because today we are running a little bit late, so we can discuss the important one.
I'll try to be quick.
Okay.
Okay. So good afternoon all. So this is the last talk of the day, and as you know, all of you must be waiting for 4 p.m. So I'll try to be quick. So Abhi, till now you have had a discussion on how to put a child on ventilator and how to monitor a child. So this talk is about how to decide about taking a child off ventilator. Okay, so ventilator se kab hatana hai. So this is the essential idea behind this talk. So as you know, mechanical ventilation is the key step while managing a child who is critically ill. But any intervention, if overdone, okay, it's not going to be productive. So discontinuation, so it's really a very important point for you to know that when to decide about taking a child off mechanical ventilator. So this is the all I would like to discuss in the subsequent 30 minutes or so. So the specific learning objectives of today's talk would be to understand the goals of weaning from a mechanical ventilator, to understand, have some basic idea about the physiological concepts underlying it, and how to test about readiness, like when to decide, how to do it, and what is the algorithm, and how do you go about extubating a child. So this is all about today's talk. So it will be covered under the following headings: the definition, what is weaning and what is extubation, what are the principles underlying it, what are the physiological aspects क्या होते हैं ventilator से out करने के patient को, And when do you feel and when you think about weaning a child from mechanical ventilation? ठीक है, तो readiness क्या होती है and किन parameters से check करते हैं, and what is failure? So failure is also important कि आपने extubate कर दिया, आपने weaning कर ली, but the child did not qualify for a good weaning and he had to be re-ventilated. So this is what failure is. So coming to the definition first, so what is weaning? So weaning is a whole process where there is a transition from ventilatory support. So a child who is on ventilatory support because of any underlying condition, and then the child gets better, the underlying condition gets better, and you transfer the child to a spontaneous mode, to a spontaneously breathing child. So this process, this transition is what weaning is all about. So this is a continuous process and this is a gradual transition. So it's not a 1 step or 2 step or 1 day procedure. So you have to definitely follow certain principles and guidelines for an effective weaning and extubation to take place. Whereas extubation is a sort of end stage of weaning where you remove the endotracheal tube. So this is called extubation, whereas weaning is the whole process. So if you consider the journey of mechanical ventilation, so as you can see here, if you consider the entire journey, so you can see there is a time when a child gets better, when you take decision that this is the time that now you have to start weaning the child off ventilator, and it's a whole process. So it's a whole process which starts from when you initiate weaning, then you follow certain steps till the time you finally take the tube out, and this is called extubation. So this is a sort of one of the last steps of weaning, but not the end, because even after the first 48 hours of taking the tube out, you have to strictly monitor the child, because this is the time when there are chances of failure as well. So there can be reasons and there can be situations where the child, perhaps weaning has not been done properly, or there can be other reasons. So when the child can be re-intubated. So this time is also important. So the main point for you to remember is it's a whole process, it's a whole transition, and it takes, if you can see, it takes almost the same time as the course of mechanical ventilation. ठीक है, तो जितना टाइम पूरा वेंटिलेटर की जर्नी में होता है, जितना टाइम उसको डालने में और लगाने में लगता है, ऑलमोस्ट द सेम टाइम उसको डिसाइड करने में और धीरे धीरे वेंटिलेटर से ऑफ करने में भी लगता है, if you want your extubation and your weaning does not fail. So if you understand the physiological aspects, so just remember two things. Ventilator से extubate करने के लिए और even wean करने के लिए, you have to remember two parameters. It's basically a optimum balance between the two parameters, which are respiratory load. That means the hurdles, the obstacles against which the child has to act, like उसका compliance कैसा है lung का, उसका elasticity कैसा है, and what is the condition of the lung parenchyma. And apart from respiratory, non-respiratory जो parameters हैं और conditions हैं which can have effect on the child's ventilatory status, like cardiovascular status कैसा है, how the child's chest wall is, chest wall resistance कितना है, and this balance has to be weighed against respiratory capacity, like जो उसकी ventilatory, जो उसका respiratory capacity है, that means the integrity of the neurological system of the child, उसका neural drive कैसा है, उसका पूरा CNS कैसा है, how he can take breathing, he can sustain breathing on his own. So ये जो physiological जो balance है of taking a child off weaning, it's a balance between the load against the capacity. So usually जो होता है, it's slightly tilted towards capacity. That means there is a lot of reserve. तो अगर even थोड़ा ये load compromise भी हो जाता है, still there is capacity. The child can have effective ventilation. But if this load, if the endurance of the lung goes beyond a critical point when the capacity cannot, the respiratory, the respiratory drive cannot sustain a physiological normal respiration, then the child requires a mechanical ventilation. Okay, so you have to maintain an optimum balance between the two. So again, coming to the same principle, if you understand how whole spectrum from a child who is on total support on the left, as you can see, till to a child who has got a normal reserve. Okay, so whenever the child is on total support, where the demands are very high and capabilities are low. Okay, maybe uska neural drive proper nahi hai, there is involvement of muscle, okay, neurological system is not intact, and the demands are high, respiratory pathology, cardiac pathology, so load is high. So the child cannot sustain spontaneous ventilation. So he is on total support. Vis-a-vis on the opposite extreme, we have a child where he is getting better. The capabilities are improving and the demands are getting low. Okay, so this is the time when you can think about. So it is very essential for you to understand the underlying reason why the child was put on ventilator, and now you feel that the child is doing fine and his capabilities are improved. That means he can sustain, अपने आप breathe कर सकता है, and the demands are low. ठीक है. So understanding this point is very important, क्योंकि अगर आप ये point समझेंगे, only then your weaning is going to be effective. Otherwise आपने time से पहले या time से बाद में किया तो it's not going to be successful. Okay. So this is always you have to remember. So ventilation and weaning from ventilation is it's in phases. It's not a 1 day or 2 day procedure. So you have certain phases. One is pre-weaning, जहाँ पर आपको कुछ prerequisites लेने होंगे, कुछ conditions देखनी होंगी कि ये सारे, if the child is qualifying and meeting all the criteria, only then you will attempt weaning. Then there is a process where you go for weaning, which is called spontaneous breathing trial. So as the name implies, बच्चा खुद से breathing करना शुरू करेगा, and you have to monitor for certain parameters. I'll come to it. Followed by extubation. If the child follows an ventilatory autonomy, if the child is maintaining and passing this SBT, then you can think about taking the tube off. So this is extubation. So when to wean? कब हम decide करेंगे कि wean करना है? So first and foremost, and obviously when the underlying disease process is improving, जब जिस भी condition के वजह से आपने बच्चे को intubate किया था, ventilate किया था, so that condition either should have improved or should show certain signs of improvement. Then only you can think about, now we can think about weaning. Then there are certain criteria, certain prerequisites, like there should be appropriate oxygenation, adequate ventilation, there should be absence of any major organ system failure, and the child should have intact airway protective mechanism. Along with that, so if you go to the subjective definition, like what is readiness to wean? So what is appropriate level of oxygenation? So any child who can maintain PaO2 of 60 millimeters of mercury, FiO2 is less than 40%, and he's maintaining well on a PEEP of less than 5. And the basic ventilator settings हो गई हैं. That means कि अब हम weaning के लिए सोच सकते हैं. He has adequate ventilatory status. ठीक है, ventilation से हटाने वाले हैं उसको. So उसका whether he can sustain अपने आप से breathe कर लेगा कि नहीं, अपना ventilatory status उसका proper है कि नहीं. So ये आपको देखना बहुत जरूरी है. उसकी intact ventilatory drive है कि नहीं. Means उसका consciousness level कैसा है. Can he follow commands? और उसका वेंटिलेटरी ड्राइव कैसी है, उसकी चेस्ट वॉल इंटीग्रिटी, मस्कुलर सिस्टम कैसा है. सो यू हैव टू टेक केयर ऑफ ऑल दीज पैरामीटर्स. और एक ब्लड गैस उसकी प्रॉपर, लाइक ही शुड हैव ऑल, जो आपको जो पहले क्लासेस में व्हिच हैज बीन डेल्ट विद इन डिटेल, कि जो उसका नॉर्मल ऑप्टिमम ब्लड गैसेस होने चाहिए. ठीक है. सो दैट मींस कि हिज वेंटिलेटरी स्टेटस इज गुड एंड यू कैन थिंक अबाउट वीनिंग इन सच अ चाइल्ड. एब्सेंस ऑफ मेजर ऑर्गन, अगेन दिस इज वेरी इंपॉर्टेंट. अगर बच्चा को आपने रेस्पिरेटरी देख लिया without looking at the cardiac status, कि वो sustain कर पाएगा कि नहीं, fluid कैसा है, whether he has any evidence of myocarditis, shock, अगर these things are present, so you should never attempt weaning. So you have to look कि grossly आपके सारे system they should be functioning fine. ठीक है. Normothermia, electrolytes are very important. ठीक है. अगर dyselectrolytemia है, then you may encounter a weaning failure. So especially potassium, magnesium, phosphate, calcium. So you have to take care of all the electrolytes. Like his ventilatory drive is good. His parameters, जो ventilatory parameters हैं बिल्कुल ही low पे हैं, and he's maintaining on that. Apart from that, he has almost normal blood gas. इसका जो है वो electrolytes normal है, nutritional status, feeding has been started, appropriate GI, मतलब all the systems are doing fine. Then you can think about weaning such children, and he should have intact airway protection. That means good cough reflex or gag reflex, दोनों चीजें preserved होने चाहिए for you to even attempt weaning in a child. तो ये सारे स्टेप्स आपको जरूर फॉलो करने चाहिए. सो दिस इज द प्री वीनिंग फेज. जब हमने सारी चीजें देखी, इफ द चाइल्ड इज मीटिंग ऑल द क्राइटेरिया, दैट मींस कि नाउ वी कैन पुट द चाइल्ड ऑन अ वीनिंग मोड, दैट इज स्पॉन्टेनियस ब्रीदिंग ट्रायल. सो ट्रायल हम एक दे रहे हैं, एंड वी आर लुकिंग वेदर द चाइल्ड कैन सस्टेन ब्रीदिंग स्पॉन्टेनियसली ऑन हिज ओन और नॉट. See, so how do we go about it? So it can be given using a T-piece with a CPAP of 5 centimeters of water. तो T-piece पे आप बच्चे को लगाते हैं, और gradually आप उसका time, you start with 15 minutes, then gradually you see if the child is able to tolerate 30 minutes to as long as 2 hours, and you see whether the child is maintaining saturation, he is passing this SBT or failing it. Okay, so you have to check. If the child fails, then definitely the child has to be put back on ventilator. और अगर बच्चा पास करता है तो आप धीरे धीरे उसका टाइम बढ़ाते जाते हैं, and then you think about extubating the child. So this SBT is a means of extubation readiness test. तो आप चेक कर रहे हैं कि अगर बच्चा जो है वो पास करता है, that means आप extubation के लिए ट्राई कर सकते हैं, and it's a weaning modality. Okay, so what is failing SBT? ठीक है, we talked about हम हर बच्चे को SBT देते हैं. So there are certain objective and certain subjective criteria which always in your case you have to look for. So what can be the objective criteria? See, if the child has tachycardia, tachypnea, hypotension. So any abnormality in the blood pressures, any abnormality in the heart rate, any abnormality in the respiratory rate. So you should feel कि ये बच्चा fail कर रहा है आपका trial. अभी he is not fit enough, and so you abort this trial SBT and put the child back on ventilator. And the subjective criteria क्या क्या होंगे? If the child complains, अगर increasing distress आपको लग रहा है, अगर उसमें जो है वो diaphoresis है, nasal flaring है, the child is looking very irritable, anxious. So these are subjective criteria. So you need to remember all those criteria. और अगर इस criteria में से कुछ भी criteria आ रहे हैं, that means अभी बच्चा tolerate नहीं कर पा रहा है weaning, and you have to put the child back on. So it is really important for you to remember these objective and subjective criteria for effective weaning to take place. Okay, so अब हमने if the child passes, so what is a successful weaning? So it is defined and classified as absence of ventilative support 48 hours. इसीलिए जो मैंने beginning में कहा था कि next 48 hours जब आप extubate करते हैं, that is really important, क्योंकि इस 48 hours में पता चलता है कि बच्चा पास कर गया है weaning को या fail कर गया. So 48 hours are really important, जहाँ पर आप ये सारे subjective, objective, and you look for any signs of deterioration in the child. Okay, if the child maintains saturation even of 48 hours, then you're happy that your weaning has been successful. And what classifies as failure? Failed SBT. आपने ट्रायल किया, उसमें ऑब्जेक्टिव सब्जेक्टिव पैरामीटर्स हुए और बच्चे को दोबारा से आपको वेंटिलेट करना पड़ गया, so that is something which is failure of weaning. So once you give a trial of weaning, so once you give a trial, I just want to add one sentence here. तो अगर SBT आपने एक बच्चे में किया है, because of any reason the child fails SBT, तो जो next SBT है that should be given not sooner than 24 hours. Okay, so you have to look for causes. क्या reasons हैं? Maybe उसके electrolytes normal नहीं है, maybe उसका disease, underlying disease has not been taken, मतलब load और capacity में अभी भी discrepancy है. So the child has failed SBT. So you have to go back and revisit the history of, फिर से आप बच्चे को examine करिए and address those issues before subjecting the child to SBT trial again. And it's not for 24 hours that you go for second SBT. So there are two ways weaning process क्या तरीके होते हैं. So there are two methods. One is the rapid or the modern method, and another is the slow or the traditional method. So slow और traditional method होता है, बहुत commonly use होता है, especially जो हमारे जो trained और जो experienced जो intensivist हैं, so they are very fond of extubating at a very late stage. ठीक है, तो बहुत ही gradual धीरे धीरे करते हैं. So where this traditional method is preferred, where you have a prolonged ventilation. अगर किसी बच्चे को आपने ventilate किया है और काफी time से बच्चा ventilated है, more than 3 days, and the disease pathology, जो pathology slow है और obviously उसकी recovery भी slow है, तो इधर this method remains very effective, जहाँ पर उसका slow बहुत दिनों से बच्चा ventilator पे है और धीरे धीरे करके improve हो रहा है. As example you can see here कि pump failure है या multi organ system failure है, so धीरे धीरे करके आप slowly उसको wean off करना शुरू करते हैं. As compared to a rapid or a modern method, where have किन conditions में effective होता है, where the child has been ventilated for a very short duration. See, there are certain indications जहाँ पर आप बहुत short duration के लिए करते हैं, जैसे post surgery है, आपके पास surgeons जो है वो after surgery जो है वो बच्चे को शिफ्ट करते हैं पोस्ट ऑप जो है स्टेज में. देन रिवर्सल ऑफ ब्रोंकियल स्पाज्म, लाइक कभी कभी एस्मा के केसेस आते हैं जहाँ पे आपको इंट्यूबेट, तो डिजीज पैथोलॉजी जहाँ पर शॉर्ट ड्यूरेशन के लिए आप वेंटिलेट करते हैं और बहुत ही जल्दी रिकवरी होती है. सो इन दोज मेथड दिस रैपिड मेथड इज वेरी इफेक्टिव, जहाँ पर आप हीलिंग जो है वो जल्दी कर सकते हैं, बहुत ही कम टाइम में. ओवर अ स्मॉल ड्यूरेशन यू कैन think about weaning the child. So what is the basis behind these two approaches? So why traditional approach? Because it's a foolproof. ठीक है, धीरे धीरे आप कर रहे हैं तो failed cautious approach है, धीरे धीरे failed extubation के chances कम होते हैं, because you are taking chances. आप धीरे धीरे बच्चे के lungs को time दे रहे हैं recovery के लिए और धीरे धीरे gradually जो है settings को कम करके and you extubate the child gradually. So but what are the adverse effects or what are the issues and the cons with it? That it increases morbidity, जितना आप वेंटिलेटर पे रख रहे हैं, and also it adds to the cost. उतनी ही वेंटिलेटर is not free of side effects. वेंटिलेटर associated pneumonias हो सकते हैं, trauma हो सकता है, and it adds to the cost. So you have to decide कि actually does the child require a traditional approach या उसको rapid कर सकते हैं. And why modern approach? Modern approach क्यों follow करता है? What is the rationale behind that? Because आपने भी observe किया होगा कि at times what happens as soon or smaller children they get better, they tend to self extubate them. होता नहीं around पे कि खुद से बच्चे ने extubate कर लिया and the child is doing absolutely fine. So that is the basis कि perhaps अगर हम सारी books को follow कर रहे होते या proper rules को कर रहे होते, तो perhaps we were over ventilating. ठीक है, बिकॉज द चाइल्ड रिस्पॉन्डेड, उसका जो कंडीशन, जो डिजीज प्रोसेस थी वो इतनी जल्दी रिकवर कर गई कि वो एक्सट्यूबेट भी उसने खुद से कर लिया एंड ही इज डूइंग एब्सोल्युटली फाइन। सो इट्स रियली इंपॉर्टेंट आपको ये देखना कि आपने किस वजह से बच्चे को वेंटिलेटर पे रखा है और कितने दिनों से रखना जरूरी पड़ा है। ओके, सो यू हैव सीन, सो दैट इज द बेसिस बिहाइंड मॉडर्न अप्रोच कि आप जो है वो स्लो, अगर आप रैपिडली शॉर्ट जो है वो इंप्रूविंग कंडीशन है तो आप उसको जल्दी से एक्सट्यूबेट कर सकते हैं एंड यू नीड नॉट रिक्वायर टू पुट हिम ऑन अ लॉन्ग वीनिंग प्रोटोकॉल। ओके, सो देयर आर सर्टेन प्रिडिक्टर्स, कुछ जैसे हर चीज में हमारे आईसीयू में प्रिडिक्टर्स होते हैं, वैसे इसमें भी प्रिडिक्टर्स होते हैं। मतलब ये सारे इंडिसेस हैं, कुछ कैलकुलेशंस हैं विच कैन हेल्प यू कि हम ये प्रिडिक्टर अगर फॉलो कर रहे हैं तो हम क्या इसको इस बच्चे को वेंटिलेट जो वीनिंग करना इसमें स्टार्ट कर सकते हैं। सो देयर आर सर्टेन प्रिडिक्टर्स लाइक रैपिड शैलो ब्रीदिंग इंडेक्स, जिसमें हम रेस्पिरेटरी रेट ओवर टाइडल वॉल्यूम का रेशियो लेते हैं बेस्ड ऑन द वेट ऑफ द चाइल्ड। सो वी हैव सर्टेन प्रिडिक्टर लाइक क्रॉप इंडेक्स, इसमें और हम रेस्पिरेटरी डायनामिक्स, लीक टेस्ट करते हैं। लीक टेस्ट इज वेयर वी गिव एयर प्रेशर और एंडोट्रेकियल ट्यूब के पास हम विद स्टेथोस्कोप वी ट्राई टू हियर ओवर द लैरिंग्स कि कितने प्रेशर पे जो है वो हमें एयर लीक सुनाई दे रही है। सो दीज आर सर्टेन प्रिडिक्टर्स कि अगर चाइल्ड इज फॉलोइंग एंड कमिंग क्वालिफाइंग द क्राइटेरिया तो हम इसको वीनिंग कर सकते हैं। तो दीज आर वेरी हेल्पफुल और बहुत सी स्टडीज एंड एडल्ट्स, but for children the studies that's a gray area. Okay, so there are few studies which say they are very sensitive, but most of the study they say कि this is got moderate sensitivity and a very poor specificity. So these predictors are not infallible. तो इसका मतलब you can take their help, आप इन predictors को use कर सकते हैं अपनी day to day practice में, but this should not be the sole basis of your decision. ठीक है, तो आपका discretion is really important. So they can act as an aid. ठीक है, लाइक डेड स्पेस फ्रैक्शन, डेड स्पेस और टाइडल वॉल्यूम का हम रेशियो देखते हैं कि डेड स्पेस कम हो रहा है, टाइडल वॉल्यूम बढ़ रही है, दैट मींस कि लंग रिकवर कर रहे हैं, अब हम वीनिंग प्लान कर सकते हैं। सो दीज आर ऑल देयर टू हेल्प यू। ठीक है, दे कैन हेल्प यू इन कमिंग एट अ डिसीजन, बट दे हैव गॉट अ पुअर स्पेसिफिसिटी। सो यू शुड ऑलवेज कीप दिस थिंग इन माइंड कि स्पेसिफिसिटी इज नॉट वेरी गुड, सो इनफॉलिबल नहीं है। सो यू हैव टू थिंक एंड यू हैव टू लुक फॉर अदर पैरामीटर्स व्हाइल कंसीडरिंग वीनिंग अ चाइल्ड। सो व्हाट आर द स्टेप्स? ठीक है, तब हमने प्लान कर लिया कि एसबीटी पास किया है, अब हम कैसे बच्चे को स्टेप्स करेंगे फॉलो। सो यू स्टॉप और टेपर सेडेशन। अगर बच्चा सेडेशन पे, ऑब्वियसली बिकॉज वी वांट सीएनएस, उसका सीएनएस बच्चा कॉन्शियस और कोहेरेंट होना चाहिए फॉर इफेक्टिव वीनिंग टू टेक प्लेस। सो यू हैव टू स्टॉप और टेपर सेडेशन ग्रेजुअली एंड यू हैव टू चेक फॉर पावर, क्योंकि बच्चे को आप खुद से ब्रीथ करना है तो क्या वो ब्रीदिंग के लायक है कि नहीं। सो यू हैव टू डू दैट, अ वेरी मेटिकुलस एग्जामिनेशन, असेसमेंट करना है क्या गैग रिफ्लेक्स, कॉफ रिफ्लेक्स है, सो दैट ही कैन swallow his own secretions. So अगर ये सारी चीजें हैं, then you have to think about look for further steps. So what are these further steps? You have to assess for peritubal leak. So as I said, usually 20-25 centimeters of water में you can look for that leak. और अगर high pressure लग रहा है, that means so it kind of gives you an idea about कि endotracheal जो है ट्यूब की वजह से वोकल कॉर्ड और लैरिंग्स में आपकी स्वेलिंग कितनी है और पोस्ट एक्सट्यूबेशन फेलियर के चांसेस कितने होंगे। सो यू हैव टू लुक फॉर एयर लीक। अगर ज्यादा हो रही है, ज्यादा प्रेशर पे हो रहे हैं, सो अगेन देयर आर फ्यू स्टडीज विच से इट डज नॉट मेक अ डिफरेंस, बट इट एक्ट्स एज वन ऑफ द प्रिडिक्टर्स। ठीक है, अगर 20-25 पे हो रहा है, दैट मींस इट्स अ गुड साइन एंड यू कैन थिंक अबाउट वीनिंग एंड फाइनली एक्सट्यूबेटिंग द चाइल्ड। ओके, डिक्रीज वेंटिलेटरी सपोर्ट ऑब्वियसली। सो व्हाट आर द वीनिंग मोड्स? हम वीनिंग कैसे कैसे कर सकते हैं? सो व्हाट आर द मोड्स? द मेन मोड्स आर SIMV, दैट इज synchronized intermittent mandatory ventilation. Then you can give it with the pressure support as well as through a TP spin, which is again a very commonly used mode of weaning. So what is SIMV? As you can see from there, synchronized intermittent mandatory ventilation. So it's a weaning mode. So what happens in that? कि आप mandatory ventilation है, उन between you see the child is gradually improving. तो वो अपने कुछ spontaneous breath ले रहा है और उसी के बीच में आप synchronized intermittent mandatory जो है ventilatory breaths दे रहे हैं. So the child's lungs and respiratory muscles are getting time to recover. कि उसकी अपनी ब्रीदिंग हो रही है और उस ब्रीदिंग को आप असिस्ट कर रहे हैं, टॉप कर रहे हैं विद योर इंटरमिटेंट मैंडेटरी वेंटिलेशन। और जैसे जैसे ये बच्चा इंप्रूव होना शुरू कर देता है, मैंडेटरी ब्रेथ को आप कम करते चले जाते हैं और स्पॉन्टेनियस ब्रेथ को ज्यादा करते चले जाते हैं, सो दैट द चाइल्ड्स लंग एंड वेंटिलेटरी सिस्टम गेट्स टाइम टू रिकवर। और धीरे, तो इट्स अ वीनिंग मोड, धीरे धीरे आप उसको ओवर टैक्स नहीं करते, बट यू गिव द चाइल्ड्स लंग टू टाइम टू रिकवर। Okay, so this is a very good way of weaning, where you can gradually wean a child from the ventilatory support. Pressure support में again you give pressure और you support child's breathing, spontaneous breathing, और धीरे धीरे करके आप pressure support को reduce करते हैं in steps of 2 to 2 और बिल्कुल minimum पर आकर then you can think about extubating the child. If the child is maintaining saturation, oxygen, everything is normal. तो gradually आप उसको मतलब एम इन सारे मीनिंग का होता है कि आप बच्चे के जो रेस्पिरेटरी ड्राइवर उसको एकदम से वेंटिलेटर नहीं हटाते, धीरे धीरे ट्रेन करते हैं. तो थोड़ा थोड़ा आप वेंटिलेटर से देते रहते हैं, थोड़ा थोड़ा बच्चा करता रहता है. एज द चाइल्ड इम्प्रूव तो आप बच्चे का कंट्रीब्यूशन ज्यादा हो जाता है, वेंटिलेटर का कंट्रीब्यूशन कम हो जाता है. If everything goes well तो आप वेंटिलेशन का बिल्कुल एक्सट्यूबेट कर देते हैं and then you monitor. So TPs is another way, pressure support, your SIMV, and then you have TPs meaning जहाँ पर आप एंडोट्रेकियल ट्यूब से आप TPs को कनेक्ट करते हैं. ग्रेजुअली इसका टाइम, ये एक मोडालिटी हमने पढ़ा था ना, रेडीनेस टू वीन में भी था. आप धीरे धीरे इसको चेक करते हैं स्पॉन्टेनियस मोड पे करके. इफ द चाइल्ड इज टॉलरेटिंग दैट मींस कि जब नाउ यू कैन थिंक अबाउट एक्सट्यूबेटिंग द चाइल्ड. So what is the role of tracheostomy? Tracheostomy जो है वो कभी कभी you must have encountered कि जहाँ पर आप बच्चा वेंटिलेटर पे होता है तो tracheostomy भी करनी पड़ जाती है. So just remember कि tracheostomy should be done after you have stabilized the child. So आपकी priority should be कि आप initially उसको stabilize कर दीजिए. और if you feel कि ये ventilation जो है वो कुछ टाइम तक persist करने वाला है, like at least for मतलब few studies से कि अब तो early tracheostomy का है. It depends upon the disease, underlying disease condition. ठीक है, 1 week to 2 weeks. अगर आपको लग रहा है कि कंडीशन ऐसी है कि 2 weeks तो लगेंगे, then definitely tracheostomy has got a role here. अगर आपको लग रहा है 2-3 days में ही एक्सट्यूबेट हम कर सकते हैं, short disease course है, and the child's recovery is very early, then you may not. Okay, so roughly 1 to 2 weeks में you think about checking for tracheostomy. But the child should be stabilized first, and extubation, as I said, is the second last step. I would say last step तो नहीं, second last step है जहाँ पर आप endotracheal tube out कर देते हैं. तो extubation is just taking the tube out, whereas decannulation is taking the जो आपने tracheostomy डाली हुई है, tracheostomy tube out. So this is the second last step. When you see everything is okay, then you extubate the child. So timing of extubation क्यों important है? बहुत ही optimum, appropriate होना चाहिए, क्योंकि अगर आपने early कर लिया है तो failure के chances हैं, re-intubate हो जाएगा और that will add to mortality and also morbidity. ठीक है, early हो जाएगा तो you will have encounter failure. और अगर आप delayed करेंगे तो chances of pneumonia, chances of ventilator associated pneumonia, chances of having trauma, and or obviously it adds to the cost. ठीक है, और ICU stay prolong करेगा. So आपको बहुत ही cautious होना होता है. It's not a very easy at times way to decide, लेकिन you have to follow all the rules and all the like the steps for effective weaning and extubation to take place. So readiness to extubation क्या है? Again the same thing कि आप check कर रहे हैं the child is readiness की है extubate करने के लिए. तो उसमें आपको क्या क्राइटेरिया होते हैं? सबसे पहले आपको देखना always the hemodynamic stability. बच्चे के vital signs absolutely normal हैं, heart rate, respiratory rate, blood pressure absolutely within normal limits. Ventilator criteria बिल्कुल ही low settings में the child is maintaining a good blood gas, everything oxygenation जो है वो उसका बिल्कुल ही proper है. Then you have to stop. Now you are thinking about taking the tube out. ठीक है, तो you have to stop feed 6 hours prior और sedation 2 hours. आपको gradually sedation को कम करना 2 hours पहले, because you want the child to be conscious and coherent enough for a proper extubation and for a proper spontaneous breathing to take place. Then extubation procedure, there are 2 ways, semi-fowlers and high. So what do you do in that? You put the patient and you have to explain the procedure that now you are going to take the tube out. And you have to suction the patient well above the pharynx, and you have to reoxygenate for some time and let the patient pacify and become cool and composed. Okay, then you have to clear the airway as much as possible, and you have to give breaths through resuscitation bag with the force so that all the secretions they come in the mouth and they can be suctioned. And when the child has breathing in the mid inspiration, then you can take the tube out. And before that, you have to explain the procedure, and again you have to see, because soon after extubation, the child may have tachycardia and tachypnea. So you have to just wait and monitor the child, and you have to give oxygen with the concentration when he was ventilated before the procedure. And you have to look for coughing, ask the child to relax, take deep breathing and relax for some time. And you have to maintain, you have to look for, again, the hemodynamic stability after you have extubated the child. And blood gas, getting one blood gas done is a good idea after you extubate the child. So again, the same thing in the algorithm, mechanical ventilation, you have to look for appropriate level of oxygenation, ventilated drive is good. There is absence of the underlying better improvement in the underlying disorder, as well as absence of any major organ dysfunction. He has got an intact airway protective mechanism. आपने SBT किया, बच्चे ने gradually increasing SBT duration को tolerate किया, then you can extubate. और अगर नहीं tolerate किया तो आप next SBT trial देंगे, but underlying conditions देखेंगे. Why did the child fail this trial? And you have to wait for at least 24 hours. before giving a second course of SBT, and you have to look for all the features or you have the subjective and objective criteria that I had talked about, जो आपको बताएंगे कि whether the child has failed or not. Then after extubation, what do you do? Most of the children, they do well with oxygen through a nasal prong या आप face mask से देते हैं, जहाँ पर आपको लग रहा है कि high risk of failure है, like बहुत time से बच्चा ventilator था और underlying condition ऐसी है जहाँ पर आपको लग रहा है कि there are chances कि he might have post airway obstruction, तो आप non-invasive ventilation देते हैं with a close monitoring for the next 24 to 48 hours, because these are crucial. So you have to look for any signs of distress, any signs of instability, any signs of airway obstruction, and you have to really monitor the child well. So non-invasive invasive ventilation after extubation, that has definitely been proven to have helpful in improving survival and decreasing the hospital stay. So if you feel that the chances of having a post-extubation failure are high, then definitely you should go for NIV. So again, this is a scoring system which can be used, like it includes inspiratory stridor, it includes air movement and retractions, and based on that, you give scoring to the child. And the score is, if it's equal to or more than 4, you have to give adrenaline nebulization. And if it's very high, as high as above 7, then you have to think about re-intubating. Okay, so jitna high ho raha hai, that means utna accessory muscles use ho rahi hai, utna retractions hai, air movement reduced hai, stridor hai, that means the child is showing signs of weaning failure. तो आपको दोबारा से उसको ventilator पे डालना होता है. Again, there is one entity called PEAO, that is post-extubation airway obstruction. This is quite frequent and is seen as high as 1/4 of the children who are extubated. So airway जब आप extubate कर देते हैं, the child has features of stridor and airway obstruction. So more commonly seen in smaller children because they have smaller airway. Large ET अगर आपने use की है, multiple attempts है, अगर airway injury हो गई है, following that there is a swelling and trauma, and the child can have. So you have to look for PEO post-extubation. इसीलिए the next 24 to 48 hours are important, because you have to look for any features, any red flag signs, any features of respiratory distress after you have extubated the children. Now again, very common question, what is the role of steroids? All of us have been using the steroids. देना चाहिए. Again, this is a gray area. There are few studies which say कि steroids का role होता है, especially adults में और बच्चों में. Most of the studies and even the Cochrane database, जो meta-analysis that says कि there is no significant improvement if you prime a child with steroids prior to extubation. Okay, तो इसका role जो है बहुत proven नहीं है. We don't have like scientific evidence to say कि steroids are definitely beneficial. But if you feel कि risk of failure are high, re-intubation के chances ज़्यादा हो सकते हैं, then you can give a trial dose of steroids, and it has to be started at least 6 hours before. And ideally आपको extubation plan करने से 12 to 24 hours पहले देने होते हैं. Multiple doses 6 hourly देते हैं आप 0.15 to 0.5 milligram per kg per dose से, and you gradually see and look for signs of distress in a child. Then what can be the complications? Because no procedure is foolproof and complications free. So थोड़ा बहुत tachycardia, tachypnea is normal after you extubate, लेकिन आपको देखना है कि कहीं prolonged तो नहीं, बच्चे में distress develop हो रहा है, laryngeal edema हो सकता है, stridor हो सकता है, vocal cord paralysis is fairly commonly seen. So those things you have to always look for after you have extubated the children. So what constitutes extubation failure? क्यों होता है? हमें failure क्यों होगा? Because abnormal respiratory mechanism, जो हमने पहले बात की थी, imbalance between the load and the capacity, perhaps we didn't take care of that. बहुत दिन अगर बच्चे को एक जो है वो इंट्यूबेटर रखा गया है, हीमोडायनेमिक इंस्टेबिलिटी है, लाइक मायोकार्डाइटिस है, लाइक न्यूट्रिशनल बहुत ही malnourished बच्चा है, सेंसोरियम रीगेन नहीं हुआ है, he has certain syndromes where because of that he is not able to sustain ventilation on his own, and infection has not been taken care of. तो इसलिए अगर आपका बच्चा even SBT फेल करता है, so you have to take care of all these points. और आपको फिर से देखना होगा कि perhaps you missed on something, इसीलिए आपने premature weaning try कर दिया, perhaps that's the reason why the child failed. So these can be the reasons and issues which you always look for in a child where you encounter extubation failure. So this is a checklist. This has one and the same thing, जो all of you, I'm sure you have, और नहीं है तो you should have in your ICUs, जहाँ पर आप उसको extubate करने से पहले सारी चीजें tick box करते हैं. So here we talk about the score and electrolytes, we talk about the hemodynamic stability, we talk about the ventilatory parameters and blood gas analysis. अगर everything is normal, that means this child is ready, और अब आप इसको आप weaning जो है इसमें plan कर सकते हैं. So this is all about the weaning and extubation. So my take home message would be, the goal for weaning from mechanical ventilation is to liberate the child from the ventilator as soon as possible. ठीक है, जितनी जल्दी सस्टेन कर सके, तो पहले भी नहीं करना है, बाद में भी नहीं करना है. इट हैज टू बी एट एन ऑप्टिमम टाइम. प्रिडिक्टिव इंडिसेस ऑफ मीनिंग बहुत प्रिडिक्टिव नहीं होते, सो यू डोंट हैव टू, मतलब इट्स नॉट समथिंग व्हिच इज रिटन इन बुक्स कि आपने एक ये वाला स्कोर है, रैपिड शैलो ब्रीदिंग इंडेक्स है, हर चीज दे आर जस्ट अ टूल टू असिस्ट यू इन डिसाइडिंग अपॉन वीनिंग. लेकिन आपका फिजिशियन डिस्क्रिप्शन होता है, जो आपका क्लिनिकल जजमेंट है, दैट ऑलवेज शुड बी गिवन द प्रायोरिटी. बेस्ट जजमेंट क्लिनिकल हमेशा जजमेंट होता है, एंड यू हैव टू लुक फॉर एसबीटी ट्रायल देना है, एंड देयर आर 3 कॉमन मोड्स ऑफ वीनिंग. टीए और 25% केसेस में आप देख सकते हैं. एक्सट्यूबेट करने के बाद यू शुड नॉट फॉरगेट द चाइल्ड, बिकॉज नेक्स्ट 24 to 48 hours आर वेरी इंपॉर्टेंट, एंड यू हैव टू यूज ऑफ स्टेरॉइड्स मे हेल्प इन. ठीक है, सो अगर आपको लगता है कि चांसेस ऑफ बहुत दिन से बच्चा इंक्यूबेटेड है, छोटा बच्चा है, ठीक है, तो देन यू मे थिंक अबाउट प्राइमिंग हिम विद स्टेरॉइड्स बिफोर taking the glucose. So this is all about I have to say about weaning in extubations, and thank you all the contributors for your effort. And any questions if you have? Okay, over from my
Thank you,
side.
Dr. Aisha, for this excellent presentation. And
do we have any questions?
There is no question.
Okay,
Your talk, so thank you.
okay, thank you.
Thank you.
Thank you.
Thank you all the participants for staying with us. So we end our session here, and tomorrow again we'll meet at 12 noon. And there are many important topics like management of shock, MIS, ARDS, and general PICU management that we will discuss tomorrow. So thank you all.